our delegates the fantastic food. I'm sure you're all having a good time. So with this, I would like to again acknowledge the main sponsors that we have. Platinum sponsored Newman's Hospital. Gold sponsors Neon Laboratories, Heart and Vascular Super Speciality Hospital. Gift sponsor Glennon Healthcare. The evening gala dinner co-hosted by Pulse Diagnostic and all our trade participants.
Yeah.
So, welcome to the most critical session of the day. We all would have handled some or the other critical emergency, but this critical session is going to be really critical, not scientifically, not academically, but biologically.
Madam, critical nahi hai. This is the most dangerous session of all the conferences, basically, because it starts at the time when your stomachs are full, the AC is perfectly cool, lights are dim, and your brain is negotiating with gravity. So, if your eyes gets closed, don't worry, we'll just assume that you are having an internal AI update. But beware, if you start snoring, then AI might report it as irregular respiratory pattern and inform the organizing team. So please be vigilant and pay attention to it.
So, we heard the first lecture, right, about AI. So, don't think that BMB doesn't have all the AI app. We can eventually monitor your snoring and everything.
Yes.
So after lunch, the only algorithm that works efficiently is food, which increases the insulin and which makes a person go into a sleep mode. So what can be done to this? Honestly, if there is an AI that could prevent post-lunch drowsiness, I'm sure somebody should try to make that. So that could be the biggest breakthrough of our MEDIMEET 2026 with the AI theme in mind. And if somebody could actually do that, I'll personally nominate that person for the Nobel Prize in Medicine. So please pay attention and let's prove that human intelligence, even post-lunch, is stronger than artificial intelligence. So now, let's power up, buckle up, fasten your seatbelt, and let's get back to pioneering the future of medicine. I promise the ideas ahead are more stimulating than the dessert that you had. I know everybody is full with dessert, but these ideas, the talks that we have post-lunch are more stimulating. So with this, I request Dr. Dharna Parekh to kindly come on the stage and introduce the first speaker. Dr. Dharna Parekh, she's a passionate dental surgeon practicing since 12 years in Borivali West. She's also a co-founder of an NGO, the Anchor Foundation, working for food of needy patients and their kids suffering from cancer. She loves swimming and exploring new places and a big-time foodie. So please welcome Dr. Dharna Parekh. Big round of applause.
Should I say good afternoon, good morning, good night? Whatever I get the response, lucky draw for it. So the next speaker of the day is Dr. Shalmali Namdar. She is a consultant physician and adult infectious disease specialist at Khopoli BMB Hospital. She is expertise in transplant and post-transplant infection. Today's topic is chest infection and in immunocompromised patient. Ma'am, we welcome you.
Thank you so much for inviting me on this forum. Today my topic is going to be pulmonary infections in an immunocompromised host. So what are the different types of immunodeficiencies that we know of? We know of granulocyte dysfunction, cell-mediated immunodeficiency, and humoral immunodeficiency. This is extremely important because when we classify the patient, first we need to classify what type of a deficiency the patient has, because depending upon the type of deficiency that the patient has, he is more predisposed to those type of infections. For example, if the patient has a granulocyte deficiency, meaning if the patient has been on certain medications that cause neutropenia, then more common infections over here would be bacterial infections. In these patients, we would not think of viral infections such as CMV or Epstein-Barr virus, but more commonly it would be bacterial or fungal infections. Just like that, if the patient has a cell-mediated immunodeficiency, for example, the patient is an HIV positive patient with a CD4 count which is low, or if the patient is a post-transplant recipient where you are on medications that cause cell-mediated immunodeficiency, then the type of infections that we would look for in those patients would be like tuberculosis, PCP, that is pneumocystis pneumonia, CMV, EBV, and other viral infections. And vis-a-vis if the patient has humoral immunodeficiency, for example, if the patient has been on rituximab, which is causing B-cell immunosuppression, then in those subset of patients, you would have different type of infections. So it is extremely important when we are classifying the patient to first understand what type of immunodeficiency the patient has. So when we talk of granulocyte dysfunction, the infections that are common are bacterial and fungal like Candida and Aspergillus. In bacteria, it is more common to have Staphylococcus aureus and gram-negative organisms, and certain anaerobes like Clostridium difficile. In fungi, you have Candida and Aspergillus. When we talk of cell-mediated immune dysfunction, we divide them into HIV and non-HIV population. HIV population would have different types of infections, and non-HIV population, that is lymphoma, leukemia, on immunomodulators for rheumatological conditions and post-transplant recipients would have a different type of infections. Now, coming to pulmonary infections, the American Thoracic Society definition for immunocompromised host with pneumonia, it is defined as an infectious pneumonia occurring in individuals with quantitative or functional impairment of host immune defenses. The diagnostic criteria for ICHP include clinical suspicion of a lung infection with or without compatible signs or symptoms, accompanied by radiographic evidence of new or worsening pulmonary infiltrates. ICHP accounts for 75% of all complications in an immunocompromised host. It is important because there is an increase in the acquired immunodeficiency due to newer advances in drugs for cancer, RA, vasculitis, and transplantations. The current guidelines recommend to obtain samples for sputum, blood, and bowel cultures for all patients who have ICHP. Advanced molecular tests such as fungal, bacterial, and viral PCRs must be used when feasible for the diagnosis. If it is a community-acquired pneumonia, then sputum and bowel cultures, gram stains, AFB smears, gene experts, and other infections such as NTM and nocardia should be thought of. If it is a hospital-acquired pneumonia, then respiratory pneumonia panels and biofire assays should be sent to ascertain the type of infection that the person has. And if we are suspecting fungal pneumonias, then we must send bile galactomannan, calcofluor stain for fungal hyphae, and serum beta-D-glucan to look for the type of fungal infection that the patient has. Now, this is a useful site because it will tell you that depending upon the type of lesions, what kind of infections are common. So if you have nodular lesions, then in an immunocompromised host, then you must think of bacterial pneumonias, you must think of Aspergillus, nocardia, mucormycosis. And if you have micronodules, then they are more common with viral pneumonias or mycobacteria. If the patient has ground glass opacities, then you should think of pneumocystis pneumonia, viral pneumonia, or atypical bacterial pneumonia. Such as Mycoplasma or Legionella. If the patient has septal thickening, then we should again think of atypical bacterial pneumonia such as Mycoplasma or Legionella. Cavitatory lung disease is more common with Mycobacteria, histoplasmosis, or Staphylococcus aureus or Klebsiella pneumonia. So the type of pneumonia or the CT picture will tell us what type of infection the person has. And based on these clinical and radiological findings, empirical treatment must be started for all patients who have ICHP. Send blood cultures prior to starting therapy, and empirical treatment must include a third-generation cephalosporin, macrolide or fluoroquinolone, and an MRSA cover. In susceptible hosts, we must also cover for PCP and fungi as directed by radiology and history. Cover with antivirals only in SOT patients who are not on prophylaxis. And we must remember that vaccinations in these people are extremely important to prevent occurrence of these infections. Now coming to my first case, this is a 54-year-old male, diabetic CKD post-renal transplant done on 6th of June. He was admitted with fever, cough and breathlessness since 10 days on 17th of August 2025. He was requiring 4 to 5 liters of oxygen to maintain saturation. Examination showed bilateral clefts. In labs, he had a WBC of 4.28, platelets of 1.13. His creatinine had increased to 3.5, and his flu panel showed that he was influenza A positive. So now, with this kind of a background, with a 10-day history of fever, cough and breathlessness in an immunocompromised host, with the WBC count being normal, and with the flu panel showing influenza A which is positive, we thought this is most likely an influenza infection. However, the duration of infection was 10 days. Now, you know commonly that viral infections usually, specifically with influenza, would not last for more than 5 to 7 days. So the fact that it was more than 7 days, it was thought that possibly there is a secondary bacterial infection that has occurred in a patient who already has an influenza A. So the patient was started on Tamiflu, oseltamivir, and meropenem and teicoplanin to cover for superadded bacterial infections. The patient continued to progressively deteriorate and was shifted to ICU and required intubation and ventilation. Now what next? Should we upgrade the antibiotics? Should we add any other antiviral or antifungal? Or should we do any other diagnostic tests? If you go to look at what we had already seen, the patient had a viral pneumonia, possibly a superadded bacterial pneumonia, and had deteriorated on the treatment that we were giving. He also had a WBC count which was normal and a CMV which was negative. So here to upgrade the antibiotics does not make any sense because the patient has come from the community. This is not a hospital-acquired pneumonia where you would think of multi-drug resistant organisms. So I don't think antibiotic upgradation would have been the good choice. Should we add any other antiviral or antifungal? So here, which other antiviral we would think of? We would only think of CMV. But we already know that the CMV viral load is not detected. So it is unlikely to be CMV. So there is no other role of upgrading or adding any other antiviral. What about antifungal? Yes, always a possibility. But because we know that influenza can trigger pulmonary invasive aspergillosis also. However, in this particular patient, we thought that we should do some additional tests to look for what pattern of infection this patient had, right? So we did a HRCT chest, and you can see what the HRCT is showing. So you can see the HRCT is showing multiple nodular consolidations with few areas of cavitations. Now, anybody wants to guess what this HRCT is? If anybody wants to guess? TB. Who said TB? Yes, absolutely. Most likely this is miliary TB. So this is a patient who's an immunocompromised patient who has a proven influenza A positive who's come with this kind of a CT which shows multiple nodular consolidations, most likely tuberculosis. So should we put this patient on empirical treatment, or do you want to do something else to prove that this is pulmonary tuberculosis? So yes, so because this patient is intubated and ventilated, doing a BAL or a bronchoscopy was extremely easy in this particular patient. And so like I said, first we define the nodules, whether they are macro or micronodular, and whether we should look for whether there are GGOs surrounding the nodules or a halo sign, because surrounding GGOs would go more in favor of fungal infections. So now we know that this CT basically looked like tuberculosis. So we did a bronchoscopy and a BAL. Now, when the chest physicians usually do bronchoscopy, they will send everything because you can't keep doing samples, right? So when we sent the pneumonia panel showed that this patient was colonized with Acinetobacter and Klebsiella. Aerobic culture also grew Acinetobacter. But you can see that the AFB smear in the bronchoscopy was positive, TB gene expert was positive, and RIF resistance was not detected. So this patient most likely had a pneumonia, most likely had influenza, and along with influenza, he had underlying miliary cox, and the reason for deterioration was most likely miliary cox. Now, since you know that this patient has no RIF resistance detected, this patient can go on first-line AKT. But we must remember that any patient who's a renal transplant patient is most likely on medications such as tacrolimus, who have an interaction with rifampin. So rifampin basically, so we must remember that rifampin is a strong CYP3/4A inducer and dramatically decreases the levels of most of the medications that they used for renal transplant, like tacrolimus, cyclosporin, or everolimus. And because of this decrease in the levels, many of the times you may have graft dysfunction. So many times in a post-transplant patient, we elect not to use a rifampin-based regimen. But before we elect not to use a rifampin-based regimen, it is extremely important to see that the patient is not resistant to other drugs. So INH monoresistance needs to be ruled out. So we did an XDR gene expert on this patient, which showed that the patient was INH resistant. Now we needed to modify the regimen to include regimens for INH resistance. So we put the patient on rifampin, pyrazinamide, levofloxacin, and ethambutol. And we kept monitoring the tacrolimus levels so that if the levels went down, we could then keep increasing the tacrolimus and there would not be any graft dysfunction. So rifampin was continued, TAC levels were monitored, and then we got the report that bal-galactomannan, which is one of the fungal markers, came positive to 4.06. So most likely this patient had TB with aspergillus. So one of the important things when we are treating an immunocompromised host is to remember that this patient can have multiple OIs. It may not be a single opportunistic infection, but multiple opportunistic infections can coexist in these patients. And whenever we are treating these multiple opportunistic infections, we must remember about the drug-drug interactions. So patient was started on rifampin, pyrazinamide, ethambutol, and levofloxacin. TAC levels were monitored. BDG and galactomannan was sent. BDG was strongly positive, 275. Galactomannan was 0.4. And in view of the bal-galactomannan positivity and the BDG being positive, a diagnosis of invasive pulmonary aspergillosis in addition to tuberculosis was made. And here the options were to treat the patient either with voriconazole or isavuconazole, but voriconazole or isavuconazole, when you combine with rifampin, actually causes the levels of vori and isavu to go down to 0. So it is basically an ineffective treatment. So that is why this patient was treated with liposomal ampho-B. So now final regimen for this patient was rifampin, PZA, ethambutol, levofloxacin, liposomal ampho-B. And subsequently, the patient improved. And you can see this is the CT scan of the patient at the end of 2 months. And you can see the miliary shadows have all resolved in this particular patient. So any questions on this particular case, if anybody has? Or can I move on to the next case? Yeah? The X-ray chest was showing miliary shadows. Yes. No, taken, it showed miliary shadows. But X-ray, when your immunity is low, it does not pick up the kind of things that you want it to pick up. So X-ray is not a good modality for a patient whose immunity is low. Because for the X-ray shadows to come up, you need neutrophils. And many of the times these patients are immunosuppressed to the level that they won't really show those shadows on the X-ray. So this is case 2. This is a 40-year-old male. He's an HIV positive who's recently detected. He presented with cough since the past 6 months and weight loss of 15 kgs and fever on and off since the past 1.5 months. And new onset breathlessness. His WBC was normal, his CRP was 150, his OTPT was borderline elevated, 50 and 70, his ALK phos was 490, GGT was 370, creat was 1.02, blood culture was no growth, patient was unable to expectorate and hence the sputum culture was not sent, and his CD4 was 14 and a viral load was 36 lakh. So this was the HRCT of this patient. So you can see multiple cavities that are present in the upper lobe of this patient. So this was a cavitatory pneumonia. Again, most likely diagnosis here would have been tuberculosis with a cavitatory pneumonia and a low CD4 count. But the bronchoscopy and BAL was done, which showed AFB smear negative and TB gene export was also negative. His BAL galactomannan was positive, it was more than 3. Serum BDG was more than 523. And we had sent a pneumocystis pneumonia workup, so that PCR had come positive. So based on this, the patient was started on voriconazole and Septran for pneumocystis pneumonia. However, the patient continued to have fever spike, had an episode of desaturation in the wards and was shifted to the ICU. Now here the workup was already done, but none of the reports were positive. And the patient had, so based on the reports, the patient was already on appropriate line of management, but the patient then had desaturation and was shifted to the ICU. So what next would you do here? So would you then plan for a CT-guided biopsy of this patient to look for any other OI that is present, or would you then possibly put the patient on empirical line of management for, to cover for tuberculosis? So anybody wants to take a guess or? So however, the patient was, first of all, the patient was not willing, and the second thing was you can see those cavities are pretty large. So there is a risk of pneumothorax when you are going to plan a biopsy for this patient. So I think we should, here when the patient is not willing, we are forced to put the patient on empirical line of treatment. But what empirical line of treatment would you put the patient on? So TB, or would you also think of some other opportunistic infections here? So I think here, when you know that the patient's CD4 is 13, so less than 50, we must also make sure that we are covering for non-tuberculous mycobacteria along with TB. So the patient was started on a treatment that covered TB as well as NTM. So we put the patient on pyrazinamide, rifampicin, isoniazid, levofloxacin, ethambutol, and amikacin, which would then cover for NTM also. And you can see the BAL culture that grew at 15 days was Mycobacterium avium intracellular, which is a non-tuberculous mycobacteria, very common in HIV positive patients. And you can see the susceptibility. The patient's isolate was susceptible to ciprofloxacin, clarithromycin, ethambutol, and moxifloxacin, however, was rifampin resistant. So the therapy was modified to include ethambutol, moxifloxacin, and azithromycin. Patient was better, there was no cough, no fever, and repeat HRCT in the month of November showed resolution of all previous lesions. You can see the cavities have completely disappeared for this patient. So coming to NTM pulmonary disease, this is a chronic pulmonary disease. In HIV positive patients, it is usually with MAC and M. consai. In HIV negative patients, it is more with rapid growers such as M. abscessus, Ginopi, Fortuchum, and Chiloni. The common presentations are bronchiectasis, endobronchial nodules, and cavitatory disease. Usually it's a slow progression, like you can see with our patient also, where the history was up to 6 months. Therefore, the patients may present with chronic cough or low-grade fever for months to years before they are diagnosed. The minimum evaluation of a patient with suspected NTM disease should include a chest radiograph, or in the absence of cavitation, an HRCT chest, and 3 or more samples for AFB, sputum samples for AFB, and exclusion of other disorders such as tuberculosis. It is very important to note that NTM can be a common colonizer, so just one sputum sample which is positive for NTM is not enough for diagnosis. So you need at least 2 sputum samples which are positive, or a single sample of bronchoscopy which is positive for NTM for the diagnosis, to clinch the diagnosis of NTM. Or last, you can do a transbronchial or other lung biopsies, which then suggests a granulomatous inflammation. So presumptive diagnosis based on clinical and radiologic features is not adequate for therapy, and isolation of NTM in cultures is essential. It should be stressed that NTM are found widely in nature, therefore contamination of respiratory specimens is common. A single positive sputum culture is not enough. NTM species that are generally not pathogenic and usually isolated due to contamination are M. gordonii, M. terrei complex, M. mucogenicum, and M. scrofulatium. So like I mentioned, diagnosis requires an HRCT which is suggestive of NTM, at least 2 sputum cultures which are positive, or a single bowel culture which is positive, or a biopsy which is suggestive of granulomatous inflammation. And the treatment is usually a combination therapy with either macrolide or ethambutol, or in severe disease like our patient had, you can add rifampin or other drugs such as an aminoglycoside or a fluoroquinolone. Now the question comes, when to start antiretroviral therapy in these patients? Usually you should wait for at least 4 weeks to start antiretroviral therapy because of the risk of NTM iris. So any questions on this second case, if anybody has? All right, so coming to my third case, this is a 60-year-old male. He's a cirrhotic, diagnosed since the past 2 years. He underwent liver transplant in October 2025. Pre-morbidly, he had multiple episodes of SBP. His stool was positive for a resistant bacteria, and perioperatively, he was given Zavicefta aztreonam and multiple other antibiotics. He was asymptomatic for a month post-transplant, but then developed fever and breathlessness. He was intubated and ventilated, required low-dose inotropes, and he was started empirically on multiple MDR antibiotics. The labs showed that he was pancytopenic. His CRP was 107. 2 sets of blood cultures were no growth, and a USG-guided aspiration was done of the abdominal. He had an abdominal collection. A USG-guided aspiration was done of the abdominal collection, which was positive for Candida auris. So based on this, it was thought that this is most likely fungal sepsis, and he was started on micafungin. A pigtail was placed to drain the collection. The patient continued to have fever and pancytopenia, and the discussion was done regarding surgery and wash for Candida peritonitis, but he was not fit for that because of low platelets. His HRCT was done, which showed multiple consolidations in bilateral lungs. So here the possibilities were either Candida auris pneumonia, but we must remember that Candida can never cause a pneumonia. So Candida auris is not a pathogen that causes pneumonia. Or this could be some other bacterial infection, but the patient was already on multiple antibiotics for that. Or what other infections are possible? So here we must do a bronchoscopy or a bronchoalveolar lavage to look for the cause. So his CMV was negative, HSV was negative, tracheal secretions was AFB smear negative, TB gene expert negative, his galactomannan was 8, and based on this it was thought that he could be invasive aspergillosis and was started on IV isavuconazole. However, the bowel culture then grew Fusarium solani complex. Now what is fusariosis? Fusariosis are hyaline filamentous fungi found everywhere in the air, water, soil, on plants and organic substances. They are soil-borne fungi. Previously it was an agro disease, but now invasive disease in profoundly neutropenic patients or immunocompromised patients is known. The clinical profile of these patients is skin and soft tissue infections. It can cause keratitis, sinusitis, pneumonia, osteomyelitis, or disseminated abscesses. Usually blood culture is positive. Definitive diagnosis requires a biopsy, and culture and speciation is extremely important because various species of Fusarium have different sensitivities for azoles. Among the hematopoietic stem cell transplant patients, it is the most common. SOTs, liver is more common, followed by lung. So here the patient was started on high-dose liposomal amphob plus voriconazole. Immunosuppression was minimized. Antifungal drug sensitivity was awaited, and patient was supported with GCSF. The final culture, fungal culture, showed that the patient was resistant to isavuconazole, sensitive to voriconazole and amphotericin B, and the patient was continued with liposomal amphob and voriconazole and showed good resolution of the pneumonias. Thank you.
Thank you. I'll request Dr. Dharna Parekh to felicitate Dr. Shalmali Namdar.
So now we'll go ahead with one more lucky draw post session. We'll get Ranna ma'am to please do the honors.
And then I'll request Dr. Dhana Parekh to kindly introduce our next speaker.
Dr. Palak Mehta. बाजू बाजू में ही मैम Ranna ma'am, please.
Next speaker of the day is Dr. Kanika Kalyani. She is an expert, leading fertility expert at Indira Hospital, Borivali. She has over 10,000 plus positive successful cycles of IVF and a decade experience of assisted reproductive technique and women's reproduction system.
A very good afternoon to all of you. Today I am going to speak on two important things. One is PCO. I'm sure all of you must have seen a lot of women with PCO. Am I right? A lot of you. Like, you know, you sometimes feel every third or fourth girl is telling she's a PCO. Okay, so it's so common a topic. And I'm talking about AMH, anti-Mullerian hormone. So, how many of you actually believe in doing AMH? Can you raise your hands? I want to know what's the opinion over here. Okay. I can see a decent number of hands, not many, but you know how I explain my patients what is actually AMH, anti-Mullerian hormone. When a female is born, she is gifted with a certain amount of eggs in her body. Okay, so it's like she has a fixed bank account with FD. Okay, now this is such an account from which she can withdraw eggs after menarche every month. As she ovulates, her egg reserve goes on decreasing, so she can withdraw eggs, but she cannot deposit eggs. So I tell my patients that this AMH is the passbook of your bank account of eggs. AMH tells as of today what is the amount of eggs in your body. Okay, so I am not saying that AMH is the only thing, but definitely I'm here to tell you that it's a very important thing. So we'll be talking about the PCOS definition, etiology, signs, symptoms, disease burden, diagnostic criteria, management, and then some cases. So PCOS is a chronic endocrine, metabolic, reproductive and psychological disorder. We all know about this with various symptoms and signs. And is primarily characterized by, so there are only three main corners. So imagine a triangle. So one is ovulatory dysfunction. Next is the PCOM morphology. So normally when we do ultrasounds, in a normal ovary, we see 8 to 10 antral follicles or maybe 6-7 follicles. If the ovarian reserve is low, we see less than 5 follicles. But if it's PCO, we see 12, 15, 20, more than 20 follicles. So they are all peripherally arranged, which we also call as a necklace pattern on ultrasound. Next is the hyperandrogenemia, and then the polycystic ovarian morphology. Now, PCOS ovaries are more than 12 follicles measuring 2 to 9 mm in diameter, and or ovarian volume of more than 10 ml in at least one ovary. PCOS is the most common endocrine disorder in women of reproductive age, with an incidence of 6 to 10% globally, regardless of ethnicity. Even when I see in my OPD, I come across so many females who are actually having polycystic ovarian morphology. Sometimes we get surprised to see कि इतना ज़्यादा हो कैसे सकता है. Then etiology of PCOS, the most important thing in PCOS, it's a lifestyle disorder. To be honest, if I talk personally, first thing that I tell my patients is only lifestyle modification and not oral contraceptive pills. Because what usually happens is we give oral contraceptive pills without, being a little strict on them that they have to take care of their lifestyle, they have to take care of their diet and exercise. If they don't, even if they take hormonal pills, the moment they stop, their cycles are again irregular. They come back to square one. So lifestyle modification is the first thing. A passive lifestyle and lack of exercise are the most common factors causing PCOS. A high calorie and high sugar diet are probable causes of exacerbating PCOS. Gut microbiota and their metabolites. So gut dysbiosis is also associated with PCOS. Genes and genetics. PCOS is linked to all genes and mutations that directly or indirectly impact the ovaries. And of course the environmental toxins such as heavy metals, insecticides. So all these are associated with PCOS. Now what is the pathophysiology of PCOS? So environmental toxins, genetic predisposition, gut dysbiosis, the diet and lifestyle, they all cause hormonal imbalance. So when we do a day 2 scan of any female, a normal scan, so we see that LH is usually less than 5 and estrogen is usually less than 50. In PCO women, LH is usually more than 10. So if it's 7, 8, 9, 10, we should suspect PCO. And so LH-FSH ratio is reversed in PCO. In hyperandrogenemia, there is increased level of testosterone and decreased level of sex hormone binding globulin. Insulin resistance is also there in PCO, decreased glucose tolerance. So all these hormonal imbalances lead to all the clinical features. And what are those clinical features? Hirsutism, the woman, because of increased level of testosterone, she gets hirsutism, oligoanovulation, irregular menstrual cycles, subfertility, and increased risk of metabolic disorders. So what I see as an IVF specialist is just the tip of the iceberg. They come to me only when they're not able to conceive and they've tried everything. But actually the iceberg is so huge. There are so many women who suffer from so many hormonal imbalances, who have some other symptoms apart from infertility. They do conceive, but still they have acne, they have persistent acne, they have hirsutism, they have irregular cycles, but infertility is not the main one, so they don't come to me. So actually the incidence is much, much more than what we think. So 70% of women with anovulation have PCOS, 70% women with hirsutism have PCOS, 40% women with severe acne have PCOS, 22% of women with androgenic alopecia. So PCOS also leads to hyperandrogenemia, and it also leads to hair loss in some women. It has such a varied presentation. Only 1 of 5 adult women are diagnosed with PCOS. Now this is very important. So many times we have females struggling with hormonal imbalances, irregular cycles, menorrhagia, but we don't know, and they also have 2 kids, but we don't know actually that they are have a case of PCOS. So it's a global disease burden of PCOS. It is estimated that what is the global disease burden? It is affecting 6% to 10% women of reproductive age globally. Up to 70% cases might go undetected worldwide due to under recognition of symptoms by healthcare providers. So this is where your role comes, because all the patients first come to you. So to detect an early PCO is very, very important, so that the woman has a better quality of life and she is, she is aware of the future chance of being infertile also, and also future risk of diabetes, future risk of hypertension, future risk of cardiovascular disease. So it's so important that when you come across all PCO or women with all these symptoms, you diagnose PCO at the right time. Recent Indian disease burden of PCOS, recent estimates suggest that it affects around 22.5% of Indian women. 1 in 5 women are affected by PCOS in India. Now that's huge. Obesity is observed in 60% of women with PCOS. Insulin resistance combined with abdominal obesity is thought to account for the higher prevalence of type 2 diabetes mellitus in PCOS. So the late consequences are impaired glucose tolerance diabetes, cardiac diseases, hypertension, hyperinsulinemia appears to be the main reason for increased cardiovascular risk of women in PCOS. Prevalence of treated hypertension is 3 times higher in women with PCOS between the age of 40 to 59 years. That is why it's so important to diagnose PCOS. Endometrial cancer, prolonged anovulation. So I'll tell you one case which happened with me. I actually had a female with PCOS. So we have a protocol that in the baseline scan, if the endometrial thickness is more than 12 mm, we first do a biopsy. We make sure that it's normal, it's not malignant, and then we go ahead with IVF. So we actually had a woman with PCO ovaries and with a very thick 15-16 mm endometrium when we did the ultrasound, and she turned out to have endometrial carcinoma. So they are at high risk of getting cancer because of unopposed estrogen. So they don't ovulate regularly. So what happens is, normally in every ovary, when I'm saying there are 8 to 10 follicles, one of those follicles dominates every month, and that follicle then ruptures and ovulation happens. But in PCOS, it's like there are so many follicles with each other. They are opposed to each other, and they don't allow a single follicle to grow. So there is no ovulation. There is delayed ovulation, and because there is delayed ovulation, there is irregular cycle. The risk appears to be, now endometrial cancer we covered, then ovarian cancer. Risk appears to be increased in nulliparous women who have multiple ovulations with early menarche and late menopause. Inducing multiple ovulations in women will increase the risk of ovarian cancer. Now there are no no very good data on this, that it causes stimulation causes cancer, but still we cannot go on and on doing ovarian stimulation. We try that we do maximum up to 3 to 4 ovarian stimulations. That too we try to do it with lower doses. There were times when we were using 300, 450 units of gonadotropins. Now we have come down to actual 150, and we have seen lower the dose of gonadotropins when stimulating, more is the chance of getting a genetically normal embryo, euploid embryo, and more is the chance of live birth rate. So we have done a study of 10,000 patients where we compared the conventional dose with the low dose, and actually lower doses have shown wonders. Breast cancer, obesity, hyperandrogenemia and infertility are key features known to be associated with the development of breast cancer. PCOS and presence of family history of breast cancer is a positive association. Now, according to the Rotterdam criteria, so primarily we have to, the latest one we have to focus on, in 2018, the first international evidence-based guideline for assessment and management of PCOS unanimously supported that Rotterdam criteria is the most widely used and accepted criteria. Now, what is that criteria? So you need androgen axis. So there are 4 categories: androgen axis and ovulatory dysfunction, androgen axis and PCO morphology, ovulatory dysfunction and PCO morphology, and last, all 3 together. So Rotterdam criteria, if we consider, we have these 4 A, B, C, D phenotypes of PCO. In the type A, we have all the 3 features. That is the anovulation plus the hyperandrogenemia plus the PCO abnormal morphology. Then the type B has no PCO morphology but the other 2. Type C has no anovulation but the other 2. And type D has no hyperandrogenemia, but it has anovulation and PCO morphology. So we have to see that, 2 of these, if they are present, they are PCO. That is the main thing that we have to understand. Now, differential diagnosis PCOS can be hypoandrogen producing tumors, androgenic alopecia, there are other causes of hyperandrogenism like Cushing's syndrome, Cushing's disease, non-classic congenital adrenal hyperplasia, hyperprolactinemia, which can be due to microadenomas or macroadenomas, and hypothyroidism. So initial evaluation of patients suspected of having PCOS should be, first we have to evaluate the cycle regularity, then androgen elevation. So when the woman comes to you, first thing is we do a good proper history taking. Does she have history of proper increased hair growth over the face? Then how is the cycle? Is the cycle regular, irregular? How is the amount of bleeding? Is the bleeding less? Is it more? And how irregular are the cycles? And of course, we can get an ultrasound done for a PCO morphology. PCOS remains the most common cause of anovulatory hyperandrogenism in adolescent and reproductive age women. A variety of other conditions need to be excluded before the diagnosis is confirmed. So in general, the areas of focus in investigating the etiology of menstrual irregularity, women with menstrual irregularity, what are the tests that we do? Usually we check for any thyroid abnormalities, you check for prolactin, basic, this is the basic. You do an ultrasound, you do a TSH, you do a prolactin, and we can do an AMH. Multidisciplinary team management is important for a person with PCOS. PCOS is associated with long-term health consequences. So early diagnosis can allow for improvement in symptoms and mitigation of long-term health complications. And patients with PCOS should have regular monitoring of their BMI, BP, metabolic parameters, and should be regular screened for depression, anxiety, and obstructive sleep apnea. So it should be a combined team work by the reproductive endocrinologist, primary healthcare provider, gynecologist, cardiologist, pediatrician, psychologist, nutritionist, and medical endocrinologist. I know it looks like a very long list, but this is where they land up eventually. When they come to you, you send them somewhere, the other person sends somewhere. So you send, if they are infertile, you send to a fertility specialist. We send them to endocrinologists also for, another opinion. And because the BMI is so high, we also send to cardiologists. So ultimately, we don't realize, but all these actually play a very important role in a PCO woman. Challenges in the diagnosis of PCOS. So what are the challenges? Diagnosis in adolescents. Adolescents must be at least 2 years post menarche to consider the diagnosis. So many of you must be getting young girls, and the mothers will complain that iska cycle start to hua, but now it's so irregular. So there are 12 to 13 years old girls, you must be coming across so many young girls who have irregular cycles, so we need not panic in that. So I explain the patients like a toddler, how the toddler learns to walk. It takes time, first the toddler will dwaddle, the toddler will fall. So the hypothalamo-pituitary ovarian axis also is like a kid between 12 years to 18 years of age. Okay, so up to 18 years, if the cycles are irregular, yes, if there are other symptoms that the girl is getting abnormal hair growth, excessive weight gain, or the sugars are high, then we have to suspect PCO. But if there is no other symptom and the young girl like 13, 14 years has an irregular cycles, we can reassure them and tell them that it's normal. And if they develop, we can warn them if they develop any other symptoms like facial hair growth or like increased weight gain, then they should come back to you for further evaluation and ruling out PCOS. So considerations may be given to the label at risk for PCOS for those in transition where the diagnostic criteria are uncertain. Like I said, irregular cycles, you should keep a follow-up with them and make sure that they don't get other symptoms of PCOS. And if they do get, we make sure that we diagnose that they are a PCO. Diagnosis in perimenopause menstrual regularity improves with aging in PCOS, so we may confuse that. Therefore, a retrospective diagnosis is necessary in this age group. Use of AMH. So now use of AMH is typically elevated in women with PCOS and reflects an increase in follicle pool. It overlaps with normal reproductive measures and hence does not sufficiently distinguish AMH. But now we see that, you know, usually, so not what we normally consider is 2.2 to 3.99. So usually I have seen a maximum PCO women have a higher AMH 3, 4, 5, 6. Pros and cons of doing ultrasound in the diagnosis of PCO morphology. So ultrasound may not be acceptable to women who are sexually inactive. Abdominal ultrasound might be limited by abdominal obesity. We never can diagnose PCO on abdominal ultrasound. This is very important for all of us to understand. PCO morphology is only and only clearly visible on vaginal. Sometimes, yes, we can clearly see, but mostly because of obesity, it's very difficult to appreciate the number of follicles in the ovary. Frequency of the transducer has an impact on diagnosis of PCO morphology. Adolescents develop multicystic ovaries. Ultrasound is definitely operator dependent, requiring expert sonographic skills and time consuming. Ovarian volume and AFC decrease with age with no specific cutoff. So these are the limitations of the ultrasound technique. But honestly now, especially, yes, being sexually inactive is a drawback for us, but if we are able to do TVS, there's nothing like it in diagnosing PCOS. Physiological role of AMH. Now, anti-Mullerian hormone is a glycoprotein produced by the ovarian granulosa cells of preantral and small antral follicles. AMH inhibits the earlier stages of follicular development. This is a very important line. AMH inhibits the earlier stages of follicular development, so there is no follicle growth, there is no ovulation, and that is why the irregular cycles. So physiology of AMH, so see in the beginning there is FSH dependent growth, and then there is arrest because of AMH, high AMH level. So FSH dependent growth is stopped, and then there is no ovulation. Role of AMH in the diagnosis of PCOS. Absence of AMH leads to an increased estradiol level in antral and pre-ovulatory follicles. In PCOS, the expression of AMH increases twofold, leading to an increased number of recruited follicles. So AMH is double, the follicles are too many which are recruited, and the high level of AMH reduces FSH expression and estradiol synthesis, thereby blocking the selection phase. So when that one follicle had to be selected, that is blocked by this high AMH. Given the challenges with ultrasound and diagnosis of PCOS, including in the years after menarche, AMH has been proposed as an alternative of marker for PCOS. So whenever you see a teenage girl, you know, very heavy built with, you know, facial hair, you are doubting. If, you know, ultrasound is very difficult, she is sexually inactive, she is unmarried, AMH is a good test to find out whether she is actually a PC or not. So AMH is, this is the Alexei's AMH plus immunoassay, and they did a study, and separate cohorts with cases of PCOS were studied. So the inclusion criteria was 25 to 45 years. Now this is the drawback here, that it can measure AMH primarily from 25 years, this particular method. PCOS diagnosis per the Rotterdam criteria classified into phenotypes A and D, and the controls were 25 to 45 with regular cycles with no previous IVF, and AFC was less than 20. Now the exclusion was congenital adrenal hyperplasia, Cushing syndrome, androgen secreting tumors, use of oral contraceptives. And in the controls, the exclusion, the PCOS diagnostics, BMI more than 40, use of OCP within 3 months of enrollment, ongoing pregnancy, of course, presence of serum beta HCG, major ovarian, endocrine or metabolic abnormalities, and any treatment going on for malignancy. Now outcome of time. Should I just wrap up?
Yeah, yes.
Okay. So this study, I'll just tell you what was the conclusion of this study. This study took cutoff of 3.2 for PCO, and it was a very good finding that maximum women who actually had PCOS fell into AMH category above 3.2. So when they kept 3.2 as a marker, it was, you know, found out in 92% cases that women with PCO morphology had AMH more than 3.2. What are the ASHRAE guidelines on PCOS diagnosis and what are their comments on AMH? Serum anti-Mullerian hormone could be used for defining PCOM in adults. So even ASHRAE says that this can be used. And there was an update in management of PCOS 2024, according to Foxy. The serum AMH level cutoff of 3.2 with the Eclexi AMH plus immunoassay exhibits high sensitivity and specificity in identifying PCO morphology, regardless of age or PCOS phenotype. So, the AMH above 3.2 is equal to polycystic ovary. Lifestyle modification I discussed, and very, very, very important. PCO woman comes to you, first thing you have to correct is vitamin D deficiency. That really leads to infertility. I think I am short of time and my message is pretty clear. Thank you so much.
Thank you, ma'am. Would like Dr. Dharna to felicitate Dr. Kanika.
Hello. I'll request Dr. Paresh Mehta to kindly come on stage and felicitate our MMC moderator.
Yeah. Dr. Rajendra Ittare, sir, our MMC observer is here. Sir, would you please join us?
Kindly give a good round of applause to our MMC observer. सर ताली बजा दो, 4 पॉइंट्स का सवाल है. Sir, the specific condition rakha. If I hear a good clapping, then only the points comes to us. Now I request Dr. Sanjay Trivedi, sir, to kindly come on the stage and introduce our next speaker.
Before that, we'll finish up with one lucky draw quickly.
Yeah.
So, Secretary BMB, Meenal Panchal. Dr. Subodh Nadkarni. So, Dr. Meenal Panchal will give the gift.
Final two.
Sir, send it.
So Dr. Sanjay Trivedi, he's a senior family physician practicing in Borivali for the last 45 years. Besides regular practice, he has special interest in chronic lifestyle disease and geriatrics. Has served in various Adivasi areas around Mumbai with other doctors and has been associated with BMB since 1985. And have organized many free medical camps and school health checkups. So Dr. Trivedi, kindly introduce our next speaker.
हो गया.
Hello. Our next speaker is Dr. Hemant Tongavkar, and he is going to speak on current trends in the treatment of ovarian cancer. He is former professor and head of the department of the urological and gynecological cancers at Tata Memorial Hospital. He has vast experience up to 35 years in this field. He is recipient of many prestigious awards and published more than 250 scientific papers and delivered many keynote addresses. So, I present Dr. Hemant Tongavkar and to give his speech.
Well, good afternoon, my dear friends. Well, at the outset, I would like to thank the Borivali Medical Brotherhood for having invited me here, and I bring you greetings from Nanavati Hospital, Nanavati Max Super Speciality Hospital rather. And I must congratulate all of you that post-lunch also there are so many people here and they are awake and asking questions. Good. Well, I'm going to speak today about ovarian cancer, something which is very dear to me. I've worked in this field for more than 35 years now, and I think I've contributed a little bit to the improved survivals in ovarian cancer. Ovarian cancer is the second commonest gynae cancer in India, but it is the most lethal gynecological cancer with the highest disease-related mortality among all gynae cancers. And this is partly because of its aggressive biological behavior and also because most of these cancers are diagnosed in advanced stages. Something which is very, very unique to our country is that most of the ovarian cancers even today are treated by non-specialists and they are given suboptimal treatment. And that's why if you want to improve the results, one of the most important approaches would be to see that all ovarian cancer patients, especially advanced ovarian cancer patients, are treated by specialists. Being an aggressive cancer, it needs an aggressive therapeutic approach, and you got to do everything right, every step of the way to ensure optimal outcomes, because it is also the most unforgiving cancer. You make one mistake along the way and you will lose the patient. Well, how do you investigate a suspected ovarian cancer? Most of them present with an adnexal mass. The presentation is most of the times very silent, and that's why it's called a whispering cancer. It will just come and whisper in your ears that I'm there. It's up to you and your doctor to, find out whether ovarian cancer is there or not. The symptoms are very vague, non-specific. Most of the patients will only say, I'm feeling a little bloated, a little distended. There's some abdominal pain or pelvic pain, and nothing more than that. Maybe some constipation, some urinary complaints which are again very non-specific, or menstrual problems. One of the most important symptoms that the patient will have, and which is often ignored by the patient and the doctor, is she'll say, थोड़ा खाना खाने के बाद मेरा पेट भर जाता है और मैं मेरा खाना complete नहीं कर सकती हूँ. This early satiety and not being able to complete her meal is the most important symptom for ovarian cancer. Lot of these patients will go to general practitioners, they'll go to gastroenterologists, they'll go to gynecologists, but many of them, you don't investigate every patient who comes to you with heartburn or occasional bloating. It is always attributed to gastroenteritis or hyperacidity, but if these symptoms are repeated or persistent, lasting more than 2 weeks at a time, then we must investigate these patients at least with an ultrasound. So the investigations usually, first of all, the clinical examination is very important, including breast examination. Investigation is actually an interplay of tumor markers and imaging. Of course, if there is some ascites or pleural effusion, we are going to draw the fluid and send it for cytology. Extremely important, whenever you do an ascitic fluid tapping, don't just do cytology. You do a cell block with immunohistochemistry and prove that it's an invasive cancer. Borderline tumors will also give positive cytology, but then you don't treat them with chemotherapy. So a cell block with IHC is extremely important. About tumor markers, again, in younger patients, of course, you do alpha-fetoprotein, beta-HCG for germ cell tumors, but for middle-aged and elderly patients, CA125, CEA, and CA19.9, all three to be done is very important. CA125, we know, is a very specific marker for, among all these three, not very specific, but specific for ovarian cancer. It can be raised in endometriosis, tuberculosis, etc., but among all these. It is important to do CEA also, because if you don't do, and if the CA is actually high, you may miss a GI cancer with metastasis to ovary. And this has happened n number of times. So this is very important that don't just do CA125, do CA also. Similarly, CA19.9, you can miss lot of other cancers if you don't do all three. So it has to be an interplay of all these three, not just one tumor marker. What about ROMA, ROCA, risk of malignancy indices, which are all present? And you get from the pathologist, you get all these reports. ROMA value is so high, ROCA is so high. Well, ROMA has all these, have an inherent component of CA125, which we know can be raised in non-cancerous conditions. So all these, in my opinion, are useless. Please don't ask for any of these investigations because they do not dictate the way you treat ovarian cancer. Basically, there are so many of them which are available, but apart from academic value, they have nothing. So any head neck cell mass, for that matter, with solid areas or papillary areas must be considered malignant unless proved otherwise. It's a simple dictum. And most commonly ignored dictum is this. I find so many patients undergoing wrong surgery, laparoscopic surgery, and you can see that there is a cyst with nice, good, solid areas there. But no, they are not considered ovarian cancer unless the patient has had surgery. If the patient has a complex ovarian mass or grossly raised markers or suspicious clinical symptoms, CT scan is mandatory before surgery. You can't just operate with ultrasound of the pelvis. And this is, again, one of the most common mistakes done in clinical practice. I have seen patients who have had just ultrasound pelvis and operated for the same, later to find that there is extensive disease in the upper abdomen, or the primary was in the upper abdomen, and you have missed something important. So a CT scan, which will tell you about the spread to the omentum, to the lymph nodes, in the root of the mesentery, bilateral masses, disease at the porta, liver metastasis, all this is extremely important to document. And I would go a step further. The ovarian cancer is one indication where PET scan actually is extremely helpful. And that's basically because what you need in ovarian cancer is precise delineation and marking of all the disease. That is possible with a PET scan. PET scan will also show you disease which is extra-abdominal. And nearly 15% of ovarian cancers have extra-abdominal disease, either to inguinal nodes, axillary nodes, cervical nodes, or pleural effusion, and so many other places. So it is extremely important for us to do this. This is one case. This lady had bilateral mucinous tumors on ultrasound of the pelvis. She was operated outside for the same. Once they opened, they found that all the mucin had come out into the peritoneal cavity. There was a rupture. They couldn't remove it, close that. Patient was sent to us. We did an ultrasound, we did a CT scan, and what did we find? That there was a pancreatic mass and ovarian masses were secondary. So it's important to do proper imaging, and we must think beyond the pelvis. What about laparoscopy? Well, role of laparoscopy in ovarian cancer is extremely limited. In ovarian cancer, especially in early stages, you are supposed to remove the masses intact, without spillage, without rupture, because that's a negative prognostic factor. And when that cannot be done through a laparoscope, then laparoscopic surgery should not be done. However, in real life, you find that there are so many things which are done. Aspiration of cysts. Sometimes you put the thing in an endo bag and then aspirate, morcellate. Please don't do this. You'll be converting a stage 1 patient into stage 3. If she was not going to require chemo, she will definitely require chemo, and she'll land up with incomplete surgery. She'll also land up with port site recurrences like this. And the explanation given, oh, she was a 20-year-old girl. Why should I give her an incision? Why should I give her a big incision? Well, scar is not as important as a life. Please don't do any harm to the patient. That's the first thing that we learn in medical school. So, if there is any suspicion of malignancy on imaging, no laparoscopy. And this is not an uncommon scenario. I told you, a large cystic mass with a solitary nodules, solid nodule. It was aspirated and the mass was excised and you found disease inside. This happened to be borderline ovarian cancer and serous cystadenocarcinoma with capsular invasion, and these patients can die just because of a wrong intervention. We also get something in the newspapers like this. City doctors remove giant ovarian cyst weighing 20 kg. No problem, so long as it's like this. No solid areas, a complete simple cyst, I have no problem whatsoever. But if there are any solid area, if there's a mucinous cyst, please don't rupture it. So early stage ovarian cancer is managed because it is managed by open surgery. It's a surgico-pathologically staged cancer, and you need to not only remove the uterus and both the ovaries, but the omentum, the lymph nodes in the pelvis and in the abdomen, and of course, wherever else you may find the disease to be. So this is extremely important because in about 20 to 30% of patients, you can upstage the tumor. That's why it should be ideally done by a gynae-oncologist, and approach should be open surgery. What about advanced ovarian cancer? We know that it's a combination of surgery and chemotherapy. Not only that, it has to be a combination of good surgery and good chemotherapy. Only then you can cure a patient with ovarian cancer. So it can be either done by primary surgery followed by chemotherapy, which is the gold standard. But when you are not able to remove or not likely to remove the entire disease, or the patient's performance status does not permit an extensive surgery, then we do a biopsy, prove that it is cancerous, give 3 cycles of chemo, after that do a surgery and treat with further 3 cycles of chemo. Well, chemotherapy, giving upfront chemo does not reduce the extent of the surgery. The aim and extent of the surgery are the same whether you do primary surgery or interval surgery. And it's common knowledge that surgical outcome depends on the size of the largest residual tumor after surgery. It's consistent and reproducible observation over the years. And what is important is complete gross resection. That means leaving no residual disease important. When I was training, it was less than 2 centimeters was optimum, then came to 1 centimeter, 0.5 centimeters. But now there is enough proof to say that when there is no zero residual, the results are the best. And they're seen in multiple trials. And that's why we need to do a complete resection. It's not important how much we remove. It's very, very important how much we leave behind. And that is why it is said that surgery is the single strongest modifiable prognostic factor. The results depend on how you do the surgery, and that's why it's a modifiable prognostic factor. So surgical paradigm has changed to increase radicality over the last decade. When I was training, surgery was very simple. TH, BSO, omentectomy, and that's it. Surgery for ovarian cancer was over in 1.5 hours. But now, we have gone much beyond that. Apart from that, we today do all these maneuvers. And this upper abdominal surgery is needed in more than 50% of patients. And with this, what's called an ultra-radical, beyond radical surgery, is the only way to cure patients with advanced ovarian cancer. Most high-volume centers do achieve that, and that's why R0 resection is non-negotiable. So what do we do? Omentectomy, but if the omentum is involving the transverse colon, you need to do a transverse colectomy with it. If it's leading up to the spleen, you need to do splenectomy or distal pancreatectomy with it. Large node mass like this in the retroperitoneum, you need to go all out and remove it completely. You also need to remove the nodes at the porta and the complete RP nodes and the pelvic nodes. Sometimes the nodes are going above the renal hilum. You also need to go and do a suprahilar dissection. Similarly, peritoneal disease, extremely common in ovarian cancer, and usually in the pouch of Douglas or over the bladder, paracolic peritoneums, subdiaphragmatic disease, or on the surface of the bowel or its mesentery. So you need to do bowel resections. It's always a temptation to shave the disease of the bowel. We don't need to do a big bowel resection. But remember, that's exactly the place where the disease is going to come back. So don't get negatively tempted. Please do a bowel resection. It's needed in at least about 40% of patients, sometimes multiple. And contrary to what is believed, only about 2.7% actually need a diverting colostomy. If you have prepared the bowel well and done a good surgery, then a colostomy is mostly not required. Peritoneal disease, wherever it is, needs to be removed. Diaphragmatic resection, again a very commonly done surgery. When I was in Tata, whenever we saw disease on the diaphragm, close. Patient, we are not going to cure this patient. We have come a long way from that. Today we can easily do diaphragmatic stripping, resection, if needed, put a patch there, and you can easily remove this entire disease with improved outcomes. Splenectomy, basically for disease, omental disease leading up to the splenic hilum, or for splenic disease itself may be required. And this is again extremely important that we do hepatic resections also for liver surface deposits and occasionally parenchymal deposits. And we have done about 36 till now, and with a good disease-free survival of more than 2 years. So just because the patient has disease on the surface of the liver or inside does not mean that the patient is incurable. You can still give the patient a chance of cure. Peritoneal carcinomatosis. If you have disease like this, limited to one area, you can do a bowel resection and remove that. But if you have multiple, then you need to spend at least an hour or so and try and remove every peritoneal deposit. Again, if the disease is confined to the abdomen and pelvis, but if the disease is there, which is in the groin, axilla, or neck nodes, then these are not limitations to surgery. You can do a node dissection in all these areas. Similarly, now we do what is called a thoracic cytoreduction. A cardiophrenic node is a very, very common site of spread in ovarian cancer. So we can either do it by VATS, that's thoracoscopic surgery, or transdiaphragmatic surgery, but it is possible to remove these lymph nodes. Now you do all this, but you do it only when, by that, you are ensuring that the whole disease is removed. If you are going to do all these big surgical procedures and leave behind disease somewhere, not acceptable. All these procedures are justified only if you are going to remove the entire disease, and then only you will get an improved progression-free survival and overall survival. So how do you ensure this? The single most important thing is radiologist has to be your best friend. You need the best quality radiology and best quality radiologist to ensure that you properly plan your surgery. You know, because there are a lot of places, they are called occult peritoneal spaces where ovarian cancer can spread, and you need to have a very good radiologist with you who can actually tell you beforehand all the sites of spread, and you can plan your surgery to do that. Of course, over a period of years, I'm sure AI is going to replace the radiologist, and that's why all of us need to learn that too. And that's why the criteria for unresectability have changed. They're not universal because the skill sets are different, the training is different, the commitment is different, the institutional backup is different. But if you look at the unresectability criteria, say about 15 years ago, you will see that even simple things, large ascites, dense adhesions between bowel and omentum disease extending to spleen, these are ridiculous inoperability criteria. So today, unless the patient has lot of disease on the surface of the bowel, extensive or its mesentery, if they are unresectable retroperitoneal nodes or portal nodes, if the patient has disease at the root of the mesentery or extensive intraparenchymal liver metastasis, then except for these, there are no indications for calling a disease inoperable. So the trend nowadays is, oh, this is an ovarian mass with some omental disease, some peritoneal disease. Let's give chemotherapy first. Completely wrong. Please do not send a patient to a medical oncologist just because the disease is outside the ovary. Let a gynae oncologist make the decision, especially in the setting of a multidisciplinary team. And most of the times you will find that these patients can be easily operable. That is why, and you must remember that giving chemo first and doing surgery followed by chemo, they do not give equivalent results. Primary surgery always gives better results than primary chemotherapy. So it is mandatory that a gynae oncologist assesses the patient, and then takes the decision. Now, these are fine. Can you identify these factors preoperatively? Well, all these years, we used to rely on a traditional method. Go to a roadside astrologer and ask the parrot to take out operable, inoperable, operable, inoperable. But I think we have moved a little beyond that. We have more objective criteria based on CT scan and assessment laparoscopy. Actually, we do a PET, FAPI PET, and that's the best that we can get. And see, this is at the root of the mesentery, like this, or extensive mesenteric involvement because of multiple nodules, or a mass which is absolutely fixed. These are the criteria, and you can easily make them out on a good quality CT scan. The second thing we do, if you are still not sure about operability, do an assessment laparoscopy, not operative laparoscopy, and you can actually do scoring. The Fagotti score, there's what is called a periperitoneal carcinomatosis index, where you assess the disease in all the quadrants, and then the score, cumulative score, if it's more than 24, it correlates with unresectability, higher rate of complications, and a poor prognosis. So we have objective means of deciding whether we should operate first or give chemotherapy first. And you have to choose wisely. You can't guess, because primary surgery, if possible, will always give better results. And this increased use of ultra-radical surgery has led to improved survival, which is seen across institutions in the world over time, and also in the registry data. You can see that with ultra-radical surgery, there's improvement in complete resection rate, and even the overall survival is significantly better. So likelihood of complete cytoreduction is a surgeon-dependent variable, what we call surgeon biology. So most patients can be optimally debulked when treated by the right surgeon in the right institution. There are, of course, people who oppose this. They say, it's the tumor biology which is important. Well, I do not know how to measure tumor biology, except that saying patients who have bulky upper abdominal disease or high-grade disease have bad tumor biology. But cytoreductive surgery is known to be effective even in those situations. So it can reverse bad tumor biology, and that's why it is always a battle between a tumor biology and a surgeon biology. One must remember that cytoreductive surgery is the only window of opportunity during which what we do can impact the patient's outcomes. Either the patient is going to have a good surgery and have long-term outcomes, or a slipshod surgery and poor outcomes. The operative time takes anything from 6 to 8 up to 11 hours. But the median survival, if you see, is much higher, more than double if you have done this kind of surgery. So no patient should be deprived of this opportunity. The morbidity is low, with mortality rate of less than 0.5%, but you need a good backup ICU team looking after these patients. So morbidity is not a deterrent. Many people will say, oh, we can't do so much, patient will not tolerate that. Build up the patient nutritionally, biochemically, do everything to ensure that the patient is optimized at the time of surgery. Do an obsessive pre, intra, and post-op management, and you will save this patient. So morbidity is not a deterrent, futility is. And this is my own data. 751 patients, one of the largest series in the world. And you can see that our complete cytoreduction rate is 83%, and survival, which used to be about 15 and 20% about 40 years ago, has now come up to 42.8%. So it is possible, even in our setting, to do and achieve very good results. Now, should cytoreductive surgery be done by a robotic method? Very good question. There are many people who do that, but if you look at the guidelines, this kind of extensive surgery cannot be done by laparoscopy or robotic surgery. So it should be done by a gynae oncologist, and it must be done by open laparotomy, and all guidelines say the same. If you want to do robotic surgery, do it in the context of a clinical trial, either institutional or global. And there also you choose patients who have responded very well to chemotherapy, hardly any disease seen, And that also should be done by a gynae oncologist who has done at least 100 open ovarian cancer surgeries. That's the ESGO guideline. And what we find that there is a breed of general surgeons, gynecologists, everybody, urologists, who are only trained in robotic surgery, not in uro-oncology or gynae oncology. And then you find people who will say, I'll remove what I can, and chemotherapy will take care of the rest. So there is no license to kill. In the words of Prokar Dasgupta, who is one of the foremost uro-oncologists and editor-in-chief of Viju International, he said, the person who sits on the robot must have a complete knowledge about ovarian cancer, how to treat it, and then maybe he can try to do this. Otherwise, a fool with a tool will always be a fool. What about HIPEC? Again, another controversial issue. There are many people who swear by HIPEC, PIPEC. It's like their heartbeats are HIPEC, PIPEC, HIPEC, PIPEC. But if you look at that, time over, last 2 slides, sorry. HIPEC only works in the setting of post-chemo surgery, okay? And that too, there's a marginal difference in the survival. So yes, it should be done in the patients who undergo interval surgery, and only those patients who have a good renal, hepatic, hematological function, who are BRCA negative, no bowel resection, no stage 4 disease. These are the patients where you can actually offer HIPEC. In primary surgery and relapse surgery, there is no proven benefit of HIPEC. So it's just an option that you have to consider. And most importantly, there are people, there's surgeons, oncologists who will tell you, I do HIPEC surgery. There's nothing like HIPEC surgery. It is a cytoreductive surgery, and HIPEC may add a little bit to the survival, but it is a surgery which adds the maximum to the surgery. So there's nothing like HIPEC surgery apart from marketing. Lastly, in relapsed ovarian cancer is usually a futile exercise, but there is a small subgroup of patients who have had a successful surgery, chemotherapy, and who relapse after 2 years, 3 years, 4 years, and a limited metastatic disease. So they seem to have a better biological behavior. Here we can do a surgery again and give good outcomes. This is grossly underutilized. We have done 30 in the last 3 years, 26 secondary, 3 tertiary surgeries, 1 quaternary surgery. Before that, in 5 years, we had done only 16. So now the awareness is increasing and the numbers are also increasing. So if you want to cure a patient with advanced ovarian cancer, it requires all these things: treatment by a gynae oncologist, training, experience, willingness, effort, ultra-radical surgery, reduction of complications, and intensive chemotherapy, including maintenance chemotherapy, and then only you cure the patient. If I have to use the words of Shakespeare, diseases desperate grown with desperate appliances are cured, or none at all. So ovarian cancer, advanced ovarian cancer, is one such desperate situation, and therefore you do your best, because doing everything right every step of the way is the only way you can cure these patients. Thank you very much.
I'll request Dr. Trivedi to kindly felicitate Dr. Tongaonkar. Big round of applause. चाय मिलेगा, don't worry. ताली बजाओ.
जो ताली नहीं बजा रहा है उसका नाम बम्पर ड्रॉ से ऐसे ही निकल जाएगा. AI is watching everything.
So before we start our next talk, let's have one more lucky draw.
Yeah. So Chaya madam will
Chaya
do the
madam.
honors.
Yes.
Video है रजत. Video.
क्या जो भी है. I'll now request Dr. S.N. Trivedi to introduce our next speaker.
Friends, our next speaker is Dr. Devendra Chaukar. He's going to talk on thyroid nodule and treatment of thyroid cancer. Dr. Devendra Chaukar is director at Nanavati Max Super Speciality Hospital. He has got extensive experience in head and neck oncology. He is a former professor and head of the department. He was awarded with the prestigious Israel Society of Head and Neck Cancer Society. He is the recipient of many prestigious awards, and he has published many papers and delivered many talks. So I call Dr. Devendra Chaukar to deliver his talk.
Hi, good afternoon, everyone, and thank you for that kind introduction. And I thank the organizers for having us here. Greetings from Nanavati, as Sir said. That's a new building. I'm sure most of you must have visited. If some of you, those who have not, please come and have a look. It's a lovely new building with great wards, ICU spaces, state-of-the-art theaters with 2 robots. Just for the organizers, we're having some prizes, right? So we'll start with a question. Those who answer correctly, maybe they can get a prize. So let us see who can answer this. What's the equation for Pakistan to qualify to the semi-finals today? Huh? नहीं होगा. Equation क्या है? You have to give me the right answer. नहीं होगा is not an answer. Huh? Sri Lanka. So they have to win by 65 runs, or they have to chase in 13.1 overs. That's the equation today for Pakistan. Okay? So now I've got your attention. Now let me start my talk. Right. So, you know, in your clinic, you will be seeing more and more of such reports. People having done PET scans and coming to you. So this is like a breast cancer who's done a PET scan. And the PET scan has reported there's a 8 millimeter nodule in the thyroid lobe. Or a patient with a bone tumor underwent a PET scan. Or somebody with a head injury undergoes a CT scan, and everything reports that there is a nodule in the thyroid. Now, as a practitioner, it is important for you to decide which one of the nodules you should take seriously and which one nodules you can observe. So that's an important decision that you have to make. And we will go through in my talk and decide what do you do with these nodules, which ones do you actually pay attention to, and which ones you can safely observe. So solitary thyroid nodule is a discrete lesion within the thyroid gland, and if we do ultrasound of every one of us sitting here, 50% will have thyroid nodules. So if you do an ultrasound, it's highly prevalent in society. Majority of us will have some nodules in their thyroid gland. Only 5 to 10% of these nodules are clinically significant. The rest 80 to 90% of the nodules are insignificant. Okay? Autopsy studies have shown that if you do autopsy studies of people who have died of other causes, up to 15 to 30% of them will have thyroid cancer. That means this thyroid cancer was there, they have lived with it and died with it. You need not do anything to that. But we are now picking up more and more thyroid nodules because we are doing more and more investigations. We are doing ultrasound, we are doing a CT scan, we are doing Doppler studies, PET CTs, and so on and so forth. And we are, what are we doing? We are overdiagnosing. We are overdiagnosing thyroid nodules. And this first was reported from Korea. In Korea, what happened, it's an interesting story. In 1999, the government initiated a screening program in Korea. They said that we will screen you free for breast, cervical, colon, gastric, and hepatic cancers. Because it was free, the practitioner, when they went to the practitioner said, "Mere ko kamai nahi ho raha hai." So they said, "You give me $30, I'll do a screening for your neck." So they did ultrasound screening of the neck, and what they found was there was a increase in detection of thyroid cancer. Okay, so post ultrasound, the thyroid cancer incidence tripled in Korea, went from around 3.5 to around 13 per 100,000, and majority of these tumors were less than a centimeter. Some of them were less than 0.5. What happened was, because now you have detected it, they underwent surgery, some of them total thyroidectomy at that time, and they had the consequences of hypoparathyroidism, injury to the parathyroid glands, and injury to the recurrent laryngeal nerve causing palsy. These cancers probably would have not caused any harm in them, but now they were being detected and being treated probably unnecessarily. So then, let's come. So what do you do when you see a thyroid nodule or when a PET scan reports that there is a thyroid nodule? First and foremost, as we are taught in our medical school, always take a good history. There are two things that can go wrong with your thyroid. One is the function. So ask for history of hyper or hypothyroidism, or nowadays, even if you don't ask, just get a TSH done. And the second and more important is you want to rule out cancer in this nodule. So what should alert you? Which of the thyroid nodule is important and needs further investigation? Extremes of age, if the patient is too young or too old. If there is radiation to the head neck in the past for some other malignancy or for some other benign condition, patient has some symptoms of compression, hoarseness or dysphagia, change in voice or change in swallowing, or there is family history of thyroid cancer. If you have all these criteria, then you must be alert and investigate this nodule further. What investigations do you do? As I said, the first investigation that you always ask for, please do not ask for a thyroid scan. Normally what happens is when you see a thyroid nodule, everybody sends it for a thyroid scan, because in medical school we are taught that a cold nodule is likely to be malignant and a hot nodule is unlikely to be malignant. But that's not the first investigation of choice. The first investigation of choice is a TSH. Okay, so do a TSH, T3, T4 TSH. If TSH is low, that means the patient is hyperthyroid. Only then you send the patient for a scan, because hyperthyroid patients, the incidence of malignancy is extremely low. So if the patient is hyperthyroid, only then send it for a scan to say whether it's a hyperfunctioning nodule or the whole gland is hyperfunctioning. So only if you have a low TSH, send the patient for a thyroid scan. Otherwise, do not do thyroid scan as the first line of investigation. After that, once you evaluate the function, then you have to evaluate the structure of the thyroid. So how do you evaluate the structure? You do an ultrasonography. After an ultrasonography, if there's anything abnormal, do an FNAC. Again, when the patient comes to you with a sonography, or ask your radiologist always to tell you this classification. It is called the Thyroid's classification. How do you know on ultrasound what are the features? Now, it's very difficult for us to remember all these features: hypoechoic nodule, irregular margins, hypervascularity, punctate microcalcification, so on and so forth. We can't remember everything in every organ. So you ask your sonologist, आप मेरे को उसको score करके दो. Give me this thyroid scoring. Thyroids 4 and 5 are suspicious. Thyroids 1, 2, 3 are not suspicious. So now you know when you see the ultrasound report, you see the thyroid scoring. 4C and above is suspicious for thyroid cancer. Send the patient for a FNAC. Again, FNAC, again it is reported by a scoring which is known as the Bethesda system. Bethesda is a place in the US where they devised this scoring system. Again, the scoring goes from 1 to 6. 1 and 2, don't worry. Usually these are benign nodules. 3 and 4, the chances of malignancy vary from 5 to 30%. And 5 and 6 are suspicious or proven. So if you have score of 5, 6, so if you have a thyroid 4 or a thyroid 5 with a Bethesda 5, then very likely that this nodule is malignant. If you have a thyroid 2 and a Bethesda 2, then you know that this nodule is benign. You can tell the patient you can safely observe this nodule. We don't need to do anything with you. The important part here is what do you do with thyroids 3 and 4? That means the incidence of malignancy varies from 5 to 30%. The patient is going to ask you, I have a chance of malignancy. आप क्या कर रहे हो? What will you further do for this nodule? Do you want to take it out or should I just observe it? Again, we go back to our history and we operate patients who have any of these high risk features. So again, as I said, extremes of age, if the nodule size is large, if the patient has family history, or there are others. So we put all the information together, the age of the patient, the sonology criteria or the sonology features. So we read the sonology carefully. We look at what type of calcification there is there irregular borders, is there hypervascularity. All this we'll look at and then make a decision whether that nodule, which is thyroids 3, 4, that means the malignancy potential is not very high, but not zero. It's between 5 and 30%. Then we'll make a call whether this patient needs to undergo surgery or not undergo surgery. So coming to thyroid cancers, once you have done all these investigations and you probably established as thyroid cancers, now thyroid cancers are vary from well-differentiated thyroid cancers to very poorly differentiated or anaplastic. So if at all one has to have a cancer in your lifetime, the differentiated thyroid cancer is the best to have. These are almost always curable. On the other hand, the thyroid, the anaplastic thyroid cancer is almost always incurable. And in between, we have other cancers such as the high-grade well-differentiated cancer, the medullary cancer, the poorly differentiated cancer, and then the anaplastic cancer. So it's a continuum of cancers from very good prognosis to very bad prognosis. Today we'll look at only well-differentiated thyroid cancer. Maybe at some other time we'll talk because the others are very, very rare. Majority of patients will have well-differentiated thyroid cancers. So surgery is the treatment for thyroid cancer. There is no other treatment for thyroid cancer. There's no chemo, there's no radiation. So, and when you treat these thyroid cancers, we must remember that they have a very good long-term survival, and hence your aggressiveness should match the risk of cancer. Okay, the punishment should fit the crime. If the crime is not much, the punishment should not be too much. So do not be aggressive in managing these cancers, because extensive surgery not always translates, as opposed to Dr. Todgavkar, who was saying extensive surgery translates in ovarian cancer. In thyroid cancer, it's exactly the opposite. Extensive surgery not always translates into increased cure rates. And the aim is to maximize survival and reduce the morbidity. Now, as you all know, this thyroid is a beautiful butterfly-shaped gland situated in front of your trachea. It has two lobes, left, right lobe joined by the isthmus. Now, if you have a nodule, how do we decide what surgery to do? What is the extent of surgery? So, if the nodule is less than 1 centimeter, the guidelines said that you can do a hemithyroidectomy. That is, remove only half the lobe of the thyroid gland. If it is more than 4 centimeters, you have to do a total thyroidectomy. Okay? So because nowadays there is a misconception in general population. Thyroid gland means total thyroidectomy. Pura gland nikal do. It's no more total thyroidectomy now. If it is less than 1 centimeter, you do a hemi. More than 4, do a total. Between 1 to 4, we are yet not sure. The guidelines are not sure what to do. Both hemi and total, but we are going more and more towards hemithyroid, and we are avoiding less and less of total thyroid because we want to avoid the complications of hypocalcemia. As I showed earlier, the incidence of thyroid cancer in Korea started increasing. Not only in Korea, all over the world they found this trend, that the incidence is increasing because we are detecting more. But if you look at the small bottom line there, the dotted line here, that is the mortality of thyroid cancer. The incidence is increasing, but the mortality is not changing. Now, if your incidence increases of any cancer, but obvious that your mortality should increase because you are getting more and more cancer in the society. What this means is we are unnecessarily detecting more cancer, and this cancer is not harmful. And because of this, then people started thinking, can we observe thyroid cancer? These are incidentally detected. 1 centimeter se kam hai. Why should we operate? Patient will live and die of these thyroid cancers. And a study was started in Japan in 1991, where they started observing less than 1 centimeter. They said 1 centimeter proven, less than 1 centimeter, let's not touch it. What we'll do is active surveillance. We'll only do ultrasound and follow up the patient with ultrasound. When they did this, they found that the incidence of tumor enlargement only by 3 millimeters was only 8% at 10 years. And patients who developed nodes were only 3.8% of 10 years. That means more than 95% of patients who have a tumor which is less than 1 centimeters do not grow in their lifetime. Okay, and you can safely observe them. This was the first study that came out of Japan. Following this, there were various other studies that were done subsequently, and then we have a criteria which say that active surveillance with ultrasound can be done for tumor size less than 1 centimeters, which is papillary thyroid, the good variant of thyroid cancers. N0 means no neck nodes, and patient is willing to comply for follow-up. That means get an ultrasound done once in 6 months initially, and then yearly later on to see the growth of the thyroid. After this publication from Japan, there were various other publications, and overall a meta-analysis was done, which again showed the same thing, that the pooled proportion of tumor growth was only 4%, rate of lymph node spread was 1%, so it was not going to lymph nodes, and the pooled mortality was 0.03%. So really these tumors which are less than 1 centimeter do not harm us. You can safely observe them or do hemithyroidectomy. So the guidelines now changed. For the less than 1 centimeter nodule, they said that you can do active, so initially it was hemithyroid. Now they said you can do active surveillance, or nowadays what we do is radiofrequency ablation. We put in a needle, and with radiofrequency under sono guidance, you ablate the thyroid nodule. So the thinking was changing from extensive surgery to less and less invasive surgery for well-differentiated thyroid cancers. Now again, when you talk of cancer, if they spread to the lymph node, all of us think this cancer is bad, it has spread to the lymph nodes. It is not true for thyroid cancer. So even if a patient comes to you with a lymph node and is detected to have thyroid cancer, you can safely tell the patient, don't worry, nodal metastasis is not a prognostic factor in thyroid cancer. It is one of the rare cancers in our body where nodal spread of a cancer is not a prognostic criteria. So even if you have nodes up to 5 nodes, the recurrence rate does not change. If you see the no nodes 4%, microscopic node 6, nodes less than 5 is 4. Only when the nodal burden increases, the risk of recurrence, and this is not mortality, this is recurrence. Only recurrence increases, it does not change the survival of the patient. So even if the patient presents with the lymph node, you can safely tell the patient, don't worry, this cancer, even if it has spread to the lymph node, is completely curable to a great extent. So during surgery, what we do is, when we are doing thyroidectomy, if the patient has nodes, we address the nodes only when the nodes are positive, that means clinically or radiologically, or the primary tumor is very large, T3 or T4, or there is a lateral neck node, then we do central compartment clearance. So thyroidectomy with lymph node dissection is usually not done for thyroid cancer unless the thyroid cancer is large or there is a clinical or radiologically present lymph node. Otherwise, we do not do thyroid cancer. So we've gone through the surgery, which is hemi or total or observation. We've done a neck dissection. So what do we do post-operative? A patient comes to you after thyroid surgery and I'll ask you, doctor, now what? What next? So I'll just walk you through what we do following surgery. Once we finish surgery, we'll put the patient in risk stratification. So we'll look at all the histological criteria, we'll look at the age, and we'll say you're low risk, intermediate risk, or high risk. So first thing we do is put the patient in a risk stratification. This risk stratification tells us whether the patient requires radioactive iodine or not. So not everybody. So most of you know that following thyroid surgery, many patients are referred for radioactive iodine therapy treatment to burn the residual thyroid tissue, especially when the patient has undergone total thyroidectomy. So we put the patient in this stratification, then decide whether radioactive treatment is necessary or not. We always do TSH suppression, again depending on the risk stratification, because thyroid cancer is TSH dependent, thyroid stimulating hormone dependent. So we always do TSH suppression by giving the patient eltroxin to suppress his TSH. That means we give thyroid hormones. And we follow up the patient with ultrasonography, thyroglobulin, which is secreted by the thyroid gland. So if the thyroglobulin starts rising, that means you know the cancer has come back somewhere. Why should a thyroglobulin rise? Thyroglobulin is only secreted by the thyroid gland, and it starts rising when you get a recurrence. So we follow up the patient with thyroglobulin, TG antibody, and an ultrasound. So as I said, we stratify the patient depending on the histology into low risk, intermediate risk, and high risk. And only intermediate and high risk we give radioactive iodine. For low risk, we do not give radioactive iodine. Some basics about radioactive iodine, and you all know, to give the patient radioactive iodine, you have to make the patient, or we used to make the patient when we were in MBBS, hypothyroid. You used to stop the eltroxin, tell the patient, total thyroid ho gaya, now stop your eltroxin, I want your TSH to go above 30, so that whatever thyroid tissue is left behind will take up the radioactive iodine and get burnt. But that is making the patient hypothyroid for 4 to 6 weeks causes a lot of problems, especially if a patient is elderly, has heart problems, has other problems. You do not want to make the patient hypothyroid. So nowadays we can do we can give T3 for about 3 to 4 weeks, then withdraw only for 2 weeks. So the hypothyroidism lasts only for 2 weeks. Or better is now we give TSH. So we give recombinant TSH, which is available in the market. So we don't have to take the patient off eltroxin. You continue the patient on eltroxin, patient is euthyroid, give the patient recombinant TSH and give radioactive iodine. Again, a misconception is radioiodine dena hai to low iodine salt khana padega. You don't, in textbooks we read cabbage mat khao, iodized namak mat khao, don't take cough syrup which has iodine, because it can interfere with radioactive iodine. But that is no more necessary. You can only take the patient off iodized salt for the last week to 10 days, and that is sufficient for it not to interfere with the radioiodine scan. We always do a diagnostic scan, and we do therapy, either ablation, we do therapy if there is residual disease, or treatment. And always we do a post-therapy whole body scan to see whether the whole, any residual thyroid tissue has been ablated. So we do surgery, we put the patient in risk stratification, that will decide radioactive iodine, and this is how we prepare the patient for radioactive iodine. Of course, we do suppression, but nowadays we do less and less suppression. Earlier it was said that suppress the patient to less than 0.1. so that there is no stimulation to whatever little thyroid tissue is left behind. That causes a lot of problems, especially in females. It causes osteoporosis, it causes cardiovascular illnesses, because you are inducing a state of hyperthyroidism. You are suppressing the TSH, the patient is in hyperthyroidism. So you do not want this to happen. So nowadays, again, the risk criteria dictate what degree of suppression we will do. If you see a report of highly suppressed TSH, go back, see what risk criteria the patient is in, and then go down, then increase or decrease the suppression depending on that. So majority of patients with thyroid cancers, we will keep the TSH to low normal. Okay, you don't have to suppress it unless the patient is very high risk, has distant metastasis, so on and so forth. Otherwise, keep the TSH at low normal. That is sufficient to control the thyroid cancer. Finally, thyroglobulin. We all know thyroglobulin is a marker for the thyroid cancers. Once a total thyroid is done, there should be no thyroglobulin in the patient's body. So thyroglobulin should be undetectable. Now we have assays which thyroglobulin is not detected. It's a very sensitive marker if patient has undergone total thyroid and radioactive iodine. Two things about thyroglobulin. One is always do it from the same lab. When you're asking for a thyroglobulin for your patient, do it from the same lab, because the lab to lab there are differences, and then the patient will have one report which says 1, one report which says 3, and then you will not know what to do, because from 1 it has gone to 3, and then you will think that the cancer has come back. So do it always from the same lab. And second, when you get a TG report in your hand, check whether that was done when the patient was taking Eltroxin or not taking Eltroxin. So if the patient has stopped Eltroxin for some time to undergo a scan, TSH is being stimulated. The thyroglobulin value will be higher than when the patient is taking Eltroxin and TSH is suppressed, because TSH is a stimulant of whatever residual thyroid tissue that is. So two things, do it in the same lab, check whether the patient is taking Eltroxin or not taking Eltroxin. That means, is the TSH suppressed or the TSH normal? And that determines your value of thyroglobulin that you will follow up the patient in post-operative period. So in a nutshell, we do either surveillance if it is less than 1 centimeter, as I said, or a hemithyroidectomy. We do total thyroidectomy for high-risk patients. After hemithyroidectomy, we do not use thyroglobulin as a marker, because half the thyroid gland is still there. We only use ultrasonography as surveillance and look at the opposite lobe and look at whether the patient is getting lymph nodes. After total thyroidectomy, we will put the patient into the risk group: low risk, intermediate risk, high risk. We'll decide whether to give radioactive iodine. We'll decide how much TSH suppression is to be done, and we follow up this patient with TG and ultrasonography. It's always a teamwork, and it's not only the surgeon, it's an endocrinologist, it's a nuclear physician, and also some of my colleagues who help me doing this. And quickly, I'll go through 2 cases. This patient presented to us with very large swelling in the thyroid. Cord was fixed. She had multiple metastases to the skeletal, lung. So the problem here was the thyroid had involved the trachea to a length where we can't resect and anastomose the trachea together again. It was not possible to get primary anastomosis after resection. So we involved a medical oncology colleague and asked, can you do something to decrease this thyroid? And nowadays, we have targeted therapy in thyroid cancer. We used lanvatinib for 6 cycles. This is a targeted therapy. It doesn't radically change it, but there was slight shrinkage of the tumor. It just moved away from the trachea a bit. There was slight shrinkage of the tumor. We went ahead and did a total thyroidectomy in this patient. We saved the trachea. One recurrent laryngeal nerve obviously had to be sacrificed. It didn't have function. But patient had a total thyroidectomy, took radioactive iodine, and had just come for a follow-up a day before. She's already about 6 to 8 months post-surgery. Another patient who presented to us with breathlessness, she had engorged veins all over her face and neck, and this was a cancer which was going down into the mediastinum. It had involved the subclavian vein. Somewhere else she was told this is inoperable, please go for proton therapy. Everybody nowadays advocates proton therapy, so she was told to take proton therapy. She came to us, and I involved my colleague Dr. George, who's a thoracic surgeon, and that is the importance of MDT or multidisciplinary care. So what we did, we made a decision of surgery because this patient would not tolerate anything else. Already a subclavian was engulfed, she had engorged veins. So we did surgery, we did a thoracotomy, we resected the subclavian vein, sacrificed the nerve on the right side. Patient had a complete resection, received radioactive iodine, and is back on follow-up, is doing well currently. So these are just a couple of examples which highlight the importance of multidisciplinary care even in thyroid cancers. Of course, for our surgeries, we always use the intraoperative nerve monitor to preserve the nerves, and these are our results. We have a temporary, the world data is 5 to 7%, we are at 5%. Most of these have recovered, temporary palsy, nerve palsies have recovered, one is not come for follow-up. We had 2 permanent palsies from about 100 cases, first 100 cases that we did, and both of them were sacrificed because of the nerve involvement. So thankfully, we don't have a permanent palsy, which is about 1 to 5% worldwide. To conclude, most thyroid nodules are benign and probably will require no treatment. Less is more is the mantra for managing well-differentiated thyroid cancer. You don't have to do extensive surgery. These are good prognostic patients. They're going to live with this thyroid cancer for their life. You don't want to do extensive surgery. Give them hypoparathyroidism. Give them nerve injury so that the voice changes. You don't want to do that. You want to do as less as possible when there is localized disease. Avoid unnecessary treatment because the survival of thyroid cancer is excellent. Thank you.
Thank you, sir. Would request Dr. Sanjay Trivedi to felicitate Dr. Devendra.
We'll have one more round of lucky draw. We'll get Dr. Meenal Panchal to do the honors.
Dr. Haresh Timbadia.
So I'll now request Dr. Sarika Katkuri to kindly come on stage and introduce the next speaker. Dr. Sarika Katkuri is a spine physiotherapist with an experience of 14 years. Has interest in classical dances and she's pursuing Kathak, loves doing yoga, adventure and trekking. So Dr. Sarika Katkuri, welcome.
Just one small announcement to be made. Sorry. We are opening a oncology OPD in Borivali, just at Dr. Navalkar's hospital, Link Road. They had forgotten to tell you that. So there now will be all our oncologists will be available at Borivali OPD. Thank you.
This is about my Nanavati Max Super Speciality Hospital. Their oncology OPD started at Dr. Navalkar's clinic at Chikowadi.
Good evening. Our next speaker is Mr. Manoj Gupta. He has worked for 11 years across wealth management, insurance, mutual fund industry and portfolio management services. He conducts 25 different type of training programs for all participants and has conducted at least 300 corporate companies training programs, and he has a lot of insights to share with us about mutual funds, equity market, debt market, real estate market, startups in financial field. So welcome Mr. Manoj Gupta.
First of all, a warm good evening to all of you. I welcome this august audience on the behalf of HDFC Mutual Fund and Chamunda Investments. I would like this august audience to say one line with me. All of you will say that one line with me? Yeah, okay. Investors, all of you say, investors cannot change their future, but they can change their habits, which can help them to change their future. Friends, we are living in a world, while I was coming for this session, that Israel and Iran are getting into a conflict zone. Today we are talking about more or less the Trump tariff phenomena which is going on. A lot of other things which are going on in the market. Last 14 months the markets have been flat. So it might be giving a lot of sleepless nights to a lot of people also. Am I on the same page with you? Correct? So what I try to do with you is, what is happening globally? Is it beneficial for India? How India is positioned currently in the markets, and within the same framework, how you can create your own winning portfolios. Coming to the turmoil which is happening currently in the world. So 3 things which I want to talk about. First, we can clearly talk about the Trump tariff which is happening. Is Trump tariff a problem for India? Is a good thing for India which is happening? What do you say? Go ahead, friends. Anybody in the group? Trump thing happening is a problem or is a good thing which is happening for India? It's an opportunity. And that is where I want to come to you. Now, when you look at the tariff thing which is happening, globally, to run any economy, 2 people are required. One, we require certainly the central bank. When we look at the Fed is saying, because of the tariff which is happening, the uncertainty in the US economy has increased, and to cut down the rates will be a very, very difficult thing. Whereas Mr. Trump says, because we have imposed the tariffs, and now the tariffs, the Supreme Court of the US itself has said it is illegal. Now because of the tariffs, lot of revenue is going to come, and because of which the growth rate in the US economy will be more. So where we look at the markets is, currently the US Fed as well as the US government stands like a North Pole and the South Pole. Whereas look at the same India in the same context. From 2020 till 2024, we were in a scenario where across the globe, the energy prices of, friends, moving up or going down? Moving up. Whereas in 2025, we got the signal that inflation is under control, and our central bank, RBI, was the first one to start cutting down the rates in India from February 2025. So RBI in India started the cycle of cutting down the rates because inflation is under control, followed by the, as a government, you can only follow 2 strategies. Either you can be reactive or you can be proactive. Mr. Trump was not doing the trade deal with us, but India, instead of following the reactive strategy, they followed the proactive strategy. September 3rd, 2025. Anybody in the group can talk about the significance of that date? September 3rd, 2025, just gone by. That was the day when the GST meeting was held, and that was the first time when we decided that GST in India need to be rationalized. When you look at the Indian economy has got 2 components. One is consumption and the other is export economy. Because of the tariff problem, export might be taking a little hit, but we try to be a proactive strategy and we try to pull up the consumption. And when you look at the Indian economy has got 2 halves. First half, friends, is the half from the April to September, and second half is from October till March. In which half we tend to consume more? First or the second half? Second half. And that is what we are seeing right now in India, that post the GST implementation, consumption both in the urban space as well as in the rural space is picking up. In every 3 seconds, we are selling 2 cars. In every 2 seconds, we are selling 3 two-wheelers right now in India. So right now we are placed in a scenario where globally the growth is going down, whereas in India, we are talking about consumption also picking up, and also now we are talking about the export factor which can be there on the upward trajectory. To talk about, according to you, friends, who is bigger, a seller or a buyer? Who is bigger? Buyer. Friends, whatever story which we give, but the fact remains that the Europeans, which are 70 odd crores, and the North Americans, which are 40 odd crore people, out of the total population of 700 odd crores, these 110 crore people are most important buyers of the world. On 27th of January 2026, first time it has happened in India that we are able to do the deal with the European Union on that given day. So we are a part of the export with those 70 odd crore people, add on to the same, now Mr. Trump is also there on the other side with us. Now 40 odd crore people, including the US and the Canada all put together, will be a part of the Indian export market. So when you look at the Indian economy currently, consumption in this economy is picking up, and this is the first time which is going to happen out in Indian economy when export they are going to do with the across all the buyers of the market, with those 110 crore odd people. That is the biggest reason I'm trying to say, when you look at this word, Amrit Kal of India, this Amrit Kal of India is going to come because this Indian economy will be a combination of the consumption as well as the export. Add on to the same, one strong statement which you always need to remember. Warren Buffett always says, I made lot of money because I was born at the right time, at the right place. And he was born at USA. Make a right statement to you? We can say proudly as Indian that we are born at the right time, at the right place, and we are born in India. In the next 20 odd years, India gives you the guarantee, whatever happens to the globe, it doesn't matter. We are going to grow by leaps and the bonds. Whatever was the stage of China 40 years back, in the next 40 odd years, we are going to be one step ahead of the same. And this is one of the slides on the Indian stock market. Some of the things which you can see on this slide. In the year 2020, when Indian stock market, friends, was trading in and around at 47,000 odd level, at that point in time, the P ratio of the Indian economy was in and around 28 levels, because earnings of the company has not come through at that point in time. Whereas, when we look at the markets in India as of today, as of 2026, though the market might be trading at the level of 82 odd thousand levels, but the fact of the matter is, the earnings of the Sensex is in and around 2.5 times what it was there in 2020. And today, the Indian market is trading at the P level of in and around 22 odd P. So Indian markets at 82,000 level currently is cheaper than what it was in the year 2020. So it makes a strong sense for each one of us to be a part of the India story as of now. Add on to the same, we have seen one of the two things which is happening currently out in India is, you can look at the same slide. Lot of FIs over a period of time out in India. Last 5 years when you talk about Indian markets, FIs has been a seller in the Indian markets or a buyer in the Indian markets? Seller. And that is what the slide is talking about. If you look whole of India, I'm still not at the back also? Okay. If you look at India's 100 rupees, then in the year 2020, out of 100 rupees, FIs used to own almost 22 odd percent. Today when we talk about India, FIs all put together, they are being net sellers in India on a yearly basis, and they only own 17% of the Indian stock market. But the fact of the India is not going to change. People like you, people like across 736 districts of India, across every pin code of India, today the domestic investors in India own much bigger amount, which you can look at the same slide, in and around 18 odd percent, and they have overtaken FIs currently out in India. Today we are living in a world where Indian market is not dependent on the FIs ownership. We are following a path that we can chart for our own trajectory. That is a strong case that I am trying to make it for you. Is today, if you are underweight on India, go overweight on the Indian portfolios. Because whatever wealth which you might have, suppose I am having wealth of 5 crores or 10 odd crores, it can easily multiply in the next 5 years or next 10 years or next 20 years for you. Because today we can say with a lot of pride that today we are not one of the bogies of the train, we are today the growth engine of the world. And the rest of the countries, whether it's Europe, North America, they are the bogies of the same train. For any investor sitting out here, what do you think is the most important word for any investor? Anybody in the group? For any investor, what is the one single important word? ROI. ROI, okay. Anything else? Capital, okay. Anything else? Risk. Risk, I agree. Returns. and you can withdraw the money through the SWP way, systematic withdrawal plan. Now in this session, in the next 5 minutes, I just want to try to explain to you a cash flow model. If you are going to implement a cash flow model for yourself in your own investment life, irrespective of the market moving up or going down, you will not have a problem. Please understand, friends, markets moving down is never a problem. Markets remaining at a lower level is always a problem. You might have seen in the year 2020, the Indian stock market corrected from the level of 40,000 to the level of 25,000. Markets coming to 25,000 is not a problem. Problem is if the markets remain at the level of 25,000 level. The only thing which has changed pre-COVID and the post-COVID. All of us travel by plane. Am I right statement to you, friends? Yes or no? Before COVID, for the domestic travel, we might be traveling with the plane owned by Mr. Goyal. Now Mr. Goyal Saab is in a different kind of a journey. We still travel by the plane, but we don't travel by the plane which is owned by Mr. Goyal Saab. Am I right statement to you? Before COVID, we were also doing the banking. We were doing a lot of banking at that point in time with Mr. Kapoor Saab. The same thing is happening with the same Kapoor Saab. We still do the banking, but a lot of banking with Kapoor Saab is not there, but we still do the banking with a lot of other banks. Meaning to say, in markets, whosoever tend to do well will remain in the market, and whatever is not going to do well, they will be automatically moved out of the markets. What you need to learn from India is, learn from the independence of this India. In 1947, when we got independence, UK or the Britishers were very, very clear that we have taken all the money of this country and this country cannot grow. After 78 years of India's independence, we can say with a lot of pride, our economy is bigger than the UK or smaller, friends? बड़ा वो जरूर बनता है जो इस दुनिया में चाहत रखता है बड़ा बनने की. और आप सब दोस्तों, with all my august audience of doctors, I will always say, be action oriented. India became big because India as a country is action oriented. They did well on agriculture, then they did well on services. Now they started doing a lot of things on the manufacturing also. And this is the only thing which you need to learn as investors on your own portfolios. Coming to a small cash flow chart for each of the investors. One of the important word which is there for all the investors is, in our industry, as you diagnose the patient, in our industry, so as to diagnose any investor, we do a process, and all of you please say this word with me, risk profiling. Please say this word with me, risk profiling. In a risk profiling, as doctors, you are asked some 15, 20 odd questions. The questions are in the format, if the markets in India go down by 10%, how you are going to feel? Somewhat happy, somewhat unhappy, and you take one of the options. Once you have completed that questionnaire, it tells you, as an investor, how much risk you are ready to take. And out of your total wealth, how much money you need to invest it into real estate, into gold, into equity mutual funds, and how much money you need to invest it into the equity PMS or the AIF or the different kind of instruments. So once you do the same, and it is said, as an investor, whatever is your risk profile, keep on following the same risk profile over a longer period of time. I take one of the example. Suppose I did the same exercise. Suppose I have got 6 odd crores to be invested. Once I did the same exercise with my distributor, with my Saki, I realized half of my money need to be invested in debt-based investments and half of my money need to be invested in equity-based mutual funds. I assume the returns. On the debt side, friends, you can look on the same slide in the column numbers C. How much returns I have assumed? 6 odd %. Whereas on the equity side, I have assumed the returns at 12 odd %. But as investor, the investor said, unlike the younger investors, I also want to take out the money on a monthly basis. You can look in the column number I, in the SWP column. The doctor wants to take out 2 lakh rupees on a monthly basis. So my distributor only told me, sir, this is your money. In the first 5 years, irrespective of the noise in the market, whether it's the Trump phenomena, Iran phenomena, or any other phenomena, do not take out the money from the
your distributor Chamunda Investment met you up for the first time almost 5 to 6 years back. 6 years back, which was the year, friends? What was happening in 2020? I think we all required you only. Correct? 2020, COVID happened. Suppose your distributor, Chamunda Investment, met you up on 20th of March 2020, saying to you, sir, if you are going to do the risk profiling, India is a growth story. Irrespective of things happening in the market, you will not lose money. Rather, you are going to multiply your own money. You started doing investments. Half of that 3 crore rupees has been invested in debt-based products, and rest of the 3 crore rupees has been invested into large cap, mid cap, small cap mutual funds out in India. Next very given day, you only said, I want to take out the money 2 lakh rupees on a monthly basis. So you are taking that 2 lakh rupees on a monthly basis from the debt side, not from the equity side. Think about you as an investor invested the money, and on 21st of March 2020, what happened, friends? COVID. My straight away question to each one of you: did any one of us in this room knew on 21st of March the lockdown is going to happen? But the fact of the matter on the investment side is not going to change. Within the span of next 15 odd days, on 20th of March, Indian stock market was trading at a level of 40,000, whereas in the next 15 days, Indian stock market was trading at a level of 25 odd thousand level. Think about you as an investor. You invested 3 crores on the equity side. In the next 15 days, that money would have become almost 50 odd percent, in and around 1.5 odd crore rupees. And there must be a sinking feeling in your heart. We were told about the Indian story. We were told that if you have to stay back, you are going to make a lot of money. And that's the time where a lot of these new kind of client gets developed out in the market. Whenever the market goes down, there is a new client which happens in the market. Can you name that client? All of you. जब बाजार नीचे जाता है, एक नया client भी आता है. Anybody can guess that client? Anybody in the group? August audience, आपके पास आता है वो हमारा patient. Go ahead. Can anybody name that client? In our Hindi parlance, it is said, one of that Panauti investor. Have you heard this guy? I am the most, one of those investors who is not going to make money. Because I invested my whole of the money thinking about India is going to grow, India is going to be the growth engine, India and America is going to come in the next 10, 15 odd years, I am going to lose out my money. And that is where all the YouTube channels start saying to you, we already told you, you keep on investing money in the real estate, into the gold, into the other investment asset class, do not invest the money in equity mutual funds. And you invested at the reason you are not making money. Have you waited only for 2 odd months, May 2020? You are already taking out the money from the debt side, so you're on a monthly basis, your expenses are taken care of. But May 2020, Indian markets came back to the level of 40 odd thousand, meaning to say your money from 3 crores on the equity mutual funds came to in and around 1.5 odd crores. It again came back to the level of 3 odd crores. Have you continued the process for the next 5 odd years? You might have taken out 1.2 odd crore rupees from your 6 crore odd corpus, and if you just look at how much money you are still, your net worth is, the column number, last column of the same presentation is talking about, you must have in and around 7.94 crore rupees as of now. You started a journey with 6 odd crores, you have taken out almost 1.2 odd crore rupees and still left with 8 odd crores. Add on to the same, I am taking the same example. The doctor said, first 5 years, I want to take out 2 lakh rupees, then I want to take out 3 lakh rupees. In the column number I, it is written out there. I want to take out 3 lakh rupees now from the equity mutual funds. You are taking out 36 lakh rupees on a yearly basis. If I run this chart, friends, for 20 odd years, for the next 20 odd years, I run the same chart. I started my journey from 6 crores. How much money I have taken it out? 6.6 odd crores. And when you look at the journey of your own net worth, then you are still making 18 odd crores. If I take this example back, 20 years back, the year was 2005 and the 6. You must have seen the Chara Ghodara 2008, the Lehman Brothers. You must have seen the European crisis. economy in the world. And today we stand as the fourth largest economy in the world. And in the next 20 odd years, if you are going to follow the path of India, you are going to multiply your own wealth, because today India stands as a $4.3 trillion economy, and in the next 20 odd years, this economy will be a more than $20 trillion economy. The choice is there with you. If there is any problem which happens, then also learn the same from India and learn from India's BrahMos. In your own life, the name of the BrahMos is a three-letter word which I want each of the investors should say with me. WHY. What it means? Why. If somebody says to you, please invest the money out here, ask him why. If somebody says to you, please shift the money from this scheme to the other scheme, what are you going to ask to him? The more number of whys you are going to ask to a distributor, the more wealth which you are going to create. How you are going to implement the same? Friends, this is your total net worth. Ask your distributor why on a yearly review. Which are the asset classes which are increasing my net worth, and which are the asset classes which are reducing my net worth. On a yearly basis, keep on adding asset classes which are increasing your net worth, and keep on removing those asset classes which are reducing your net worth. If you are going to play this game for 10 odd years, then number of winners are going to increase in the portfolio, and number of losers will move out of the portfolio. If the losers move out and the winners increase in the portfolio, the risk of the portfolio will move up or move down. If it's going to move down, the returns are going to move up. That's the most basic philosophy of doing investment. And my sincere request for this August audiences, today, once you are back at your home, create your own video of 10 odd seconds. What are you going to do in this particular video? Just talk about, in the last year, what you did right in the investment thing, and what wrong you did on the investment side. Next year, again see your own video. Whatever right which you are doing, follow the same, and whatever wrong which you are doing, do not repeat the same mistake. Over a period of 10 odd years, friends, only 100 seconds of your own video will make your mistakes or reduce your mistakes, and once your mistakes are reduced, your risk of the portfolio is going to go down, and the return of the portfolio is going to move up. Just to summarize the session in a switch short format for you. Suppose there's an investor who might have gone to the Chamunda Investments talking about, if I do my investments across time frames, will I going to make money or no? I just take an example for investing the money across some of the funds and created a portfolio in the year 2016. So a lot of investors, so some of the date which is written out there, 2016 they invested the money across large caps, mid caps, flexi cap, and all the other categories of the fund. And you realize over a period of time, once you stick with the same portfolio with 10 odd years, any guesses how much the portfolio value would I might have become? Any guesses? One of the important part which you can look at, the last column out there. Very important for a lot of investors out there. Just look at the absolute number which it might have become. Something might have become 4 times, some might become 2 times, some might have become 3 odd times. Because the fact of the matter is, in the year 2016 and 17, we were almost the 10th largest economy, and from the 10th largest economy in the last 10 odd years, we have become the 4th largest economy in the world. So to summarize the session, friends, for each one of you, if you want to understand investments, only learn it from India. And India is teaching us that we do not need to focus on the returns, we need to focus on the risk. Just like our India, focus on all the 3 aspects, agriculture, services, and manufacturing. As investor, why you do the investment? Focus on all the asset classes. You will need gold, silver. You will also need the equity mutual fund, the PMS, the AIF in your own portfolio. Second, ensure India is growing because India is growing their net worth on a yearly basis. What you need to do, or you need to learn from India is how we are going to increase our net worth on a yearly basis. And to increase the net worth, the better phenomenon is known in the world is to follow the cash flow model. Even with the best of the knowledge, a lot of mistakes are going to happen.
not a problem. The way I told you, whenever India faces a problem, they always ask the why with themselves. And whenever you want to ask a why, you will get the right answer, what the mistake which I am making as of now. And once you correct the same, India is the one of the stories which is going to give you so much of the returns which you might have not thought of. We have also said, lot of people who do not change, वो क्या हो जाते हैं दोस्तों? जो लोग बदलते नहीं हैं वो कौन हो जाते हैं? नोकिया हो जाते हैं। और जो लोग बदलना जानते हैं वो लोग इंडिया हो जाते हैं। सैमसंग तो कहीं और का है। मैं अपने सेशन को क्लोज करने से पहले दो चीजें करना चाहता हूँ। What I want is सब लोग मेरे साथ हरिवंश राय जी की दो लाइनें बोलो, all the doctors, and then we'll close the session. क्योंकि हरिवंश राय की दो लाइनें शायद सब सारे इन्वेस्टर्स के लिए बहुत यूजफुल रहेंगी। सब लोग बोलेंगे मेरे साथ? ओके, लहरों से डरकर नौका पार नहीं होती, कोशिश करने वालों की कभी हार नहीं होती। मार्केट के उतार चढ़ाव से डरकर इन्वेस्टर की नौका पार नहीं होती। म्यूचुअल फंड में निवेश करने वालों की कभी मैं रिक्वेस्ट ऑगस्ट ऑडियंस फॉर लास्ट एक्सरसाइज, कैन यू स्टैंड अप वंस फॉर दिस सेशन एंड देन वी क्लोज द सेशन। एक बार सब लोग खड़े हो सकते हैं, ऑल ऑगस्ट ऑडियंस, व्हाटएवर आई एम सेइंग प्लीज डू द सेम। वन लास्ट एक्सरसाइज, प्लीज रेज योर राइट हैंड। ओके, ट्राई टू मेक अ फ्लावर लाइक दिस। इस तरीके से फ्लावर की कोशिश कीजिए। Put this flower on your chin. Put this flower on chin. बहुत अच्छा। chin कहाँ पर होता है डॉक्टर्स? बाहर जाओगे वही पुरानी कहानी। Sorry डॉक्टर्स, आप सबको मैंने खड़ा कर दिया। What Manoj was speaking, पता नहीं क्या बोल रहा था, उसको क्या पता? रियल एस्टेट में सारा पैसा लगा देते तो 4 गुना हो जाता। Only one thing I want to teach through this session is, दूसरों की देखा देखी करना छोड़ दो। अगर ये करना छोड़ दोगे, बाकी का काम आपका इंडिया कर देगा। थैंक यू सो मच विशाल भाई, थैंक यू।
Thank you.
अगर कोई सवाल है, मैं उन सवालों को आप एड्रेस कर सकता हूँ।
I'll request Dr. Sarika
Yeah.
to felicitate Mr. Manoj. Time for one more lucky draw. किंजल सर, आप निकालो लकी ड्रॉ। वीना आचार्य, डॉक्टर वीना आचार्य। डॉक्टर अशोक विश्वाडिया। मॉर्निंग यू गॉट ना सर? मॉर्निंग यू गॉट द प्राइज राइट? देन हाउ कम यू हैव पुट 2? हाँ, you have got wins. So this is proper. किंजल सर, भागो नहीं। So we'll move ahead. We'll have our PFT workshop.
So I'll request Dr. Sarika to introduce the 3 speakers for our PFT workshop.
Our next 3 speakers are a team with Dr. Kinjal Modi, Dr. Shyam Sundar Tampi, and Dr. Professor Jaya Lakshmi. I'd like to introduce first Dr. Kinjal Modi. He is a consultant pulmonary physician. He has done his MBBS, MD, DNB in India, FCCP in USA, and interventional pulmonology from Malaysia. He's been practicing for 2 decades at PD Hinduja Hospital, Khar, and many hospitals in the suburbs like the Criticare Asia, Suchak, Apex and Lotus group of hospitals, etc. His special interests are in asthma, COPD, ILD, OSA, bronchoscopy, TB and critical respiratory care. He has also done LLB and LLM from Mumbai University. Now, Dr. Kinjal Modi would like to introduce his fellow doctors.
PFT. So, very good afternoon to all of you. जाग रहे सो गए खाना अच्छा था पता है मेरे को गुड इवनिंग बोल सकते हैं अग्री टू दैट सो खाना काफ़ी अच्छा था लेकिन परेश सर ने क्या बोला है मोदी है ना बोलते अच्छा है तो सबको जगा के रखेंगे लास्ट तक उनको रखो इसलिए पीएफटी वर्कशॉप लास्ट में रखा हमारा हाँ या सो वी आर बेसिकली we are a group of 3 doctors over here and a technician. We'll try to teach you how to interpret, show you how PFT is done and all those things in a matter of 1 hour time. Next slide please sir. Yeah, so this is, next, click kar dijiye. So this is the disclaimer is, this is the whole PFT workshop has gone by sponsorship of American College Chest Physician, the Western chapter. Next slide please. So why this topic? Small video, voice call. 1 minute. So, repeat.
Yeah, so we are organizing a PFT workshop in BMB MEDIMEET this year to make you understand how to interpret these values in graphs. So come, let's understand the PFT better so that we can make our patients understand the PFT better so that they can be treated in a better way. Thank you so much.
Thank you. Yeah, so your team today, Dr. Shyam Sundar Thampi, Dr. Jayalakshmi Madam, myself and our technician Mr. Kiran. So starting with the introduction of Shyam Sundar sir, a very eminent personality. He is a mix of 2 things. He is a mix of an army person, a navy person and a medical person. Sir has worked in Ashwini for many years. Apart from that, he was the first DM pulmonologist of Mumbai city. So very rare to have that character. Presently sir is a senior most consultant at Bombay Hospital as well as sir practices at Kambala Hill Hospital also. He is a DNB teacher. He is the president-elect of Western Chapter, American Society of Chest Physicians. So has numerical publications, various awards. Recently, sir given oration at TESCON conference last year, and we received various lifetime achievement awards also. Thank you. Next slide. She is Dr. Jayalakshmi Madam. Madam is practicing presently at Apollo Hospital, Navi Mumbai. She has done her post-graduation from Nair and graduation from KM Hospital, and she was a gold medalist in the DTRT. She is a professor and head of the DY Patil Hospital in Navi Mumbai, and she has completed her European Respiratory Diploma in 2013. She was a part of the COVID task force, which was very eminent at that time. She is herself a yoga teacher also, and she keeps on learning. Madam has presently done. We can see that in 2013, means after her completion of so many years, she has learned 1 more degree. Then after a couple of years, she had done a pediatric sleep medicine course. And her motto is keep learning, teaching, and growing, and strive for excellence always. So this is our team to help you today to learn the PFT. Next slide. So the theme is, we'll first show you how the PFT is done. So what does simple how the PFT technicians try to do? Actually, he also got a train, so actually we have to get him early, and we should only the pre part. So basically, the pre and post both are there. What is there, we'll discuss in the later part of the stage. But he will do. Please, there, aa jayenge idhar. So he will start with the how to do a spirometry. Next, we'll have the history and basics by Thampi sir. But I think the madam will precede her. The madam also has to leave now. The various lung functions which are included in PFD apart from spirometry, right? And lastly, I will go on again the interpretation of the spirometry in hands-on. We have given papers to you, so basically we'll try to keep you how to understand and interpret it. Next slide. So now we start with the spirometry part. किरण भाई, आप चालू करो. इनका लैपटॉप कनेक्ट कर सकते हैं? Yes. ये कनेक्ट होगा? किरण भाई, थोड़ा यहाँ बैठ जाएंगे, लैपटॉप कनेक्ट हो जाएगा आपका. थोड़ा इधर बैठ जाओ ना, कंप्यूटर कनेक्ट हो जाएगा. रहने दे सकते. So we'll try to have a live demo of the how spirometry is done, how his vitals have been filled, and
And your height? Do you are smoking or no?
spirometry generally depend on the age and the height of a person. We think weight is also important, but spirometry weight is not important for the calculations basically.
So start.
Start. But you're gonna help of a AV guy only. He does not know anything of spirometry. So basically, a new person doing a spirometry first time. So basically, he also will have a first-hand experience.
मिस्टर बासुदेव सर, ये हमारा लंग फंक्शन टेस्ट है. उसमें आपको क्या करना है? ये मशीन आपको हाथ में रखना है.
एक माइक है.
इसके अंदर ये माउथ पीस लगाना है.
अब वापस बोल.
Just wait, sir.
So initially they ask the patient which language they are comfortable with. They try to explain the procedure. ये क्या करने वाले हैं? फूंक मारना है and all those things. Setting up the machine.
बासुदेव सर, ये हमारा लंग फंक्शन टेस्ट है. इसमें हमें क्या करना है? ये मशीन आपको हाथ में रखनी है. ये माउथ पीस है, हम लोग इसमें लगाएंगे. माउथ पीस लगाने के बाद आपको इतना मुंह के अंदर रखना है. मुंह के अंदर रखने के बाद जब मैं आपको इनहेल करने के लिए कहूँगा, यानी सांस अंदर खींचने के लिए, उस समय आपको इस तरह से इनहेल करना है. ओके. जब मैं आपको एक्सहेल करने के लिए कहूँगा, इनहेल करते समय आपका प्रेशर हमारे स्टमक के ऊपर होना चाहिए. एक्सहेल करते समय हमारा प्रेशर स्टमक के ऊपर होना चाहिए. ओके. ये मशीन आपको हाथ में रखनी है. इतना मुंह के अंदर रखना है, मुंह पूरा बंद रखना है. आप मुंह के अंदर रखिए, मुंह पूरा बंद रखना है. मुंह से आपको पूरा सांस अंदर खींचना है. जोर से फूंक मारना है. छोड़ो.
फूको जोर से.
नहीं, गलत. देखो, जब मैं आपको इनहेल करने के लिए कहूँगा, अंदर खींचना है. खींच के दिखाइए मुझे आपको. ये निकालिए, खींच के दिखाओ. जोर से खींचना है सर. और खींच के दिखाओ फिर से. यस. जब मैं आपको एक्सहेल करने के लिए कहूँगा, फूंक मार के दिखाइए मुझे. जोर से फूंक मारो. फूंक मारिए इसके ऊपर. ऐसे नहीं, ये देखो. मारिए. और जोर से. यहाँ से होना चाहिए, पेट से. मुंह के अंदर.
Small manuals to teach how the patient to blow. पेशेंट जोर से फूंक मारेंगे नहीं तो रिपोर्ट गलत आता है.
रखो बिटवीन द टीथ. मुंह के अंदर रखो. मुंह बंद रखना है पूरा. खींचो जोर से. फूंक मारो. छोड़ो छोड़ो. नीचे झुकना है पूरा. नीचे. सर इसको बाहर नहीं निकालना है.
This happens regularly with the patients.
देखो, जब आप छोड़ते हो ना, तो ये मुंह के बाहर नहीं निकालना है. आपको मुंह के अंदर ही रखना है. ठीक है. चलो वंस मोर टाइम.
जब बोलेंगे तभी निकालना है. आपने अच्छा किया था. ऐसे ही करो.
जोर से खींचो. फूंक मारो. छोड़ो छोड़ो. नीचे झुकना है पूरा. जाने दो थोड़ा और. सर
निकालना नहीं है.
निकालना नहीं.
आपने सांस इधर फूका ना, वापस लेना भी है. निकालने बोलेंगे आप.
जब तक मैं कहूँगा तब तक आपको छोड़ना है. अब जब सांस छोड़ते हो तो एंड में आपको ऐसे फील होगा कि बॉडी के अंदर कुछ भी एयर बचा नहीं है. थोड़ा आपको घुटन जैसा महसूस हो रहा है, तो उसके ऊपर आपको ध्यान देना नहीं है. सिर्फ आपका प्रेशर मेंटेन रखना है, मैं जब कहूँगा तब तक छोड़ते रहना है, ओके? वेट, मुंह से लंबा सांस खींचो, फूंक मारो, छोड़ो छोड़ो छोड़ो, नीचे झुकना है, थोड़ा और थोड़ा और थोड़ा और थोड़ा, पुश करना है, पुश करना है, थोड़ा थोड़ा, खींचो अंदर जोर से,
बस हो गया।
अच्छा किया है। मुझे और एक बार चाहिए, जब आप इनहेल करते हो, सांस अंदर खींचते हो, ऐसे होना चाहिए, ओके? चलो वंस मोर टाइम, खींचो जोर से, फूंक मारो, छोड़ो 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 छोड़ो, अगेन जोर से खींचना है। वेरी गुड, बस बस,
चलो
निकालो,
चलो।
बहुत अच्छा किया है।
So you can see that he had tried to blow with 6 seconds. So 6 second criteria रहता है. So at least वो काफी लोग क्या एक फूंक मारा खत्म करके छोड़ देते. This is not the way it's done. At least you have to blow for 6 seconds. We'll continue. ठीक, that's all. Thank you. Thank you Kiran ji. Thank you Mukul ji. So next speaker is Thampi sir. Sorry, Jayalakshmi madam. She will be speaking on the various lung function tests apart from spirometry. MacBook है जरा उसका connection तो उसका
इनका करना है, बस हो गया।
डालो।
कनेक्टर है, हा लावायचं. हे काढूया ना, नाहीतर पडणार ते.
केबल घेऊन येतो. अच्छा आहे ना.
बरोबर. आपके पास है कनेक्टर?
आई थिंक so युवराज सर ने सही बोला था कि अपन AI सीख रहे हैं बट अभी भी PPT लगाने में तकलीफ होता है. तो मैकबुक रहेगा तो ज़्यादा तकलीफ होता है. दैट्स द ओनली थिंग.
कनेक्ट नहीं हो रहा.
हैपेंस.
नहीं कनेक्ट नहीं करना.
ऐसे अपना लास्ट टॉक है, चिंता नहीं है, बट ओनली थिंग इज दैट जल्दी खत्म हो जाएगा तो अपने को जल्दी रूम जाके थोड़ा आराम मिलेगा और कुछ नहीं. हाँ, आप लोग को बोलो, हमको कहाँ आराम मिलता है सर? अभी आपका शाम का प्रोग्राम नहीं करने का, शाम का प्रोग्राम करने का ना रंजित सर, तो फिर बराबर ऑर्गेनाइज सेक्रेटरी सो जाएगा तो कैसे चलेगा? बराबर. तो
हेलो,
या थैंक्स.
हेलो, सुनाई दे रहा है ना? चालू नहीं. हेलो, hello, yeah, okay. So thanks to BMB, thanks to ACCP, thanks to Dr. Kinjal for inviting me for this session, and thanks Dr. Thampi for allowing me to speak first. So we saw the demo of the PFT. Details about the PFT will be told by Dr. Thampi, how the spirometry, about the scientific aspects and about the theoretical part. We will discuss about the other PFTs apart from the lung function test or the spirometry. So we will be talking about the FINO, the DLCO and the FOT. Many times you must be seeing these reports but not really understanding what they are all about and why to do them and when to do them. So just if you have a female who's having breathlessness and you examination is normal, you're getting the chest, you're doing, what will you do? You will check the peak flow, which is a small equipment where you can just ask the patient to blow. I don't have a picture of it. And then, or we can do a pheno test. So what does pheno do? It gives us an idea of whether there is a type 2 inflammation or a eosinophilic inflammation, or whether this person will respond well to steroids. Also, we can do a bronchoprovocation test. Means just like how you saw the PFT, you give them a bronchodilator inhaler and do the test. That's called as a bronchodilator response. Or you can give them something which can cause a bronchoprovocation, something like an histamine or some ipratropium derivatives that can cause a bronchoconstriction in these patients. So you give a muscarinic agent which can cause a bronchoconstriction. So these tests also you can do. And plus we can do this is not very commonly done. Then we have the oscillometry, which is being more and more popular, especially in the pediatric patients. And then you can do the allergic evaluation, that is you can do a skin prick testing. So this is the PFT which we saw. Dr. Thampi will be telling about the details. Suppose the PFT is normal or the PFT is not enough and you want more information, then what will you do? We can go for the pheno. So basically pheno is done in asthma patients. You do it to see whether there is an eosinophilic inflammation or not. And what information do you get? You get a clear number. You get a number in 62, 19, 38. So if it is a high number, it means there is more of eosinophilic inflammation. If it is a low number, it means there is a less of eosinophilic inflammation. And if it is in between, so around 25 is usually the cutoff, where you say less than that is less in eosinophilic inflammation and more than that. But this is also very useful to see patients whom you are following up. Now suppose you have done a PFT, you see that there is obstruction, you diagnose asthma and you give inhalers. After the inhaler, if the patient has a response, so after 15 days or 1 month, you can again check the pheno. So this pheno which was high really goes down to normal. So if you have an acute eosinophilic or acute attack of asthma, the pheno will be very high. But if you give the patient steroids, inhalers and check it, after some time the pheno would have come back to normal. So this is a very good test to see whether this patient is going to respond to inhalers and how much is the response. Basically, nitrous oxide is an endogenously produced gas. It acts as a gaseous signaling molecule really, and it acts as an epithelial-derived relaxing factor synthesized from L-arginine, and there are 2-3 forms. And it is upregulated by the inflammatory cytokine, that is IL-4, 13, TNF-alpha, IL-1. Therefore, it increases the NO production in the airway epithelium. It is suppressed by glucocorticoids. It has a physiological role as well by modulating the bronchial tone and the vascular tone, and it reflects the airway inflammation. So basically you see it to see eosinophilic inflammation, steroid responsiveness, and to guide the treatment decisions. Usually done in acute asthmas, and this is the cutoff. Less than 25 eosinophilic inflammation unlikely, more than 50 likely, 25 to 50 we interpret it cautiously. So it can be diagnostic, predictive as well as prognostic. So we will not go into that. Now next, another patient, 48-year-old female with breathlessness, no smoking, no wheezing, occasional joint stiffness, no prior TB. So the history saturation is low. We are getting a history Velcro crepe suggestive of an interstitial lung disease. Joint pain, so we need to rule out collagen vascular disease. So you have a interstitial pattern on the CT scan. So what will you do? Spirometry, CT scan, DLCO, 6-minute walk test, all of the above. Basically, you will have to do all because you want to judge, one, what is the disease, second, what is the severity. So all your PFTs are going to give you an idea of the severity of the disease. So we will come to this. Important thing is that the lung function, especially in connective tissue disorders, can show impairment even before the CT scan can show any abnormality or before the X-ray can show abnormality. So you get a restrictive defect in the PFT in these patients. So this is an example of a lung function test with a restrictive abnormality. And we will go into the DLCO, which is a diffusion study. So there are some factors which you see the DLCO. You see the KCO, which is a DLCO by the alveolar, divided by the alveolar volume. So in this patient, if you see the DLCO is coming to be 35% of predicted, which is very low. So this shows that the person has an impaired lung diffusion, probably because of lung thickening or because of interstitial thickening or because of destruction of the alveoli because of the interstitial thickening. So this is how the DLCO picture looks like. This is how you will get the report. So you will have a best, you will get a percentage predicted. If you see the very first value in the DLCO, single breath value, you see that there is 7.40 predicted. Best value is 2.86 of the patient, and it is only 39% of the predicted. So this shows that the person is having a severely reduced DLCO. This means the diffusion component of carbon monoxide for the patient is very low. Why carbon monoxide is selected? Because normally carbon monoxide has a very high affinity to hemoglobin and it diffuses very fast, even better than carbon dioxide or oxygen. Hence, that is used for testing. So basically, the person inhales a prefixed percentage of the carbon monoxide. After inhalation and exhalation, you calculate how much that percentage has reduced. So with this, you will come to know how much has diffused with some calculations. So that is all that is the theory to it. So basically, diffusion capacity is also known as you can also calculate the transfer factor. You get values like alveolar volume, and you get the KCO, which is the CO transfer coefficient. KCO is the small KCO by barometric pressure, and it is written as a DLCO by alveolar volume. It gives basically an index of transfer of carbon monoxide. And it also gives the permeability factor, which is the rate constant for alveolo-capillary carbon monoxide transfer. We don't need to know much of the theory. We need to know where we should use this test. So we see when the person is becoming breathless, why is the patient breathless? Why is the patient hypoxemic? So whether it is an obstructive disease like an emphysema. Usually in asthma, the DLCO will be normal. But when there is emphysema, there is also destruction of the alveolar tissue. So basically, DLCO doesn't give you an idea of the airway problem. Like asthma, you have obstruction, which is best seen in the pulmonary function test. But the DLCO will be reduced whenever there is a lung parenchymal problem. So parenchymal problem in the alveoli can be destroyed alveoli because of emphysema. So even COPD patients, you will have a reduced DLCO. Most ideally, it will be reduced, and it is used in patients with a restrictive lung disease like interstitial lung disease. So in interstitial lung disease, the DLCO is very specific. So whenever there is any clouding of the interstitium or filling of the interstitium with water, as in pulmonary edema or in alveolitis or in sarcoidosis, so in all these conditions, you will find that the DLCO is reduced. In them, the PFT may be relatively normal, or there may be mild restriction, moderate restriction. The DLCO is extremely sensitive, and it will give us an immediate idea as to whether how bad it is, how much it can also be used for follow-ups to see after therapy how much improvement is there. It's also seen prior to lung resection surgery, whether to detect and see the severity of the disease before starting oxygen for the patient. Although for that, the more important criteria is the arterial blood gas to see whether patient requires oxygen or not, and for follow-up. So basically, contraindications, nothing much. This is the technology. Is basically you make the patient do few deep breaths, take a deep breath again, hold the breath, and then release the breath. So you come to know how much volume has got diluted at the end of the breath out. This is how you calculate the difference. So it's based on simple principle of volume and pressure. So you ask the patient to breathe in, hold the breath, expire, see how much of the user effective, but for this only thing is that the patient should have an effective breath holding time. When you inhale, like you saw this technique was difficult, even DLCO technique, patient's cooperation is required. Patient has to inhale, hold the breath for a particular period of time and then release it slowly. Only then you will be able to calculate how much of the gas is diffused. So patient's cooperation and patient's capability is important in this. Some patients with very severe disease are not able to perform the test. So we'll not go into the details of this thing. So the values, DLCO percentage, 80% is a normal cutoff, 79 to 60% mild reduction, 59 to 40% moderate reduction, less than 40% is a severe reduction. It can depend on age, sex and size as well. It can depend on cigarette smoking. So in smokers, you may get slightly altered values. You will get altered values in high altitude. In some patients who have had a pneumonectomy, or they are not able to expand the lung completely, like they have kyphoscoliosis, one part of the lung is reduced because of pneumonectomy, or there is a pleural effusion or fluid. In these patients also the DLCO will be reduced because the total volume which is taking part in the diffusion is reduced. So not because of interstitial problem, but because of total volume problem also you can get a reduced DLCO. That gets somewhat corrected by using the equation of DLCO upon the total volume. So using the VA. So when you see the KCO, you may get a more accurate reflection because you are seeing the diffusion per unit volume. So in interstitial lung disease, DLCO is decreased by alveolar capillary damage. KCO is also often reduced. Pulmonary vascular disease, DLCO is reduced and the VA may be typically normal. So there are various cases where you can see the alveolo. So if you see the first condition, that is there is a neuromuscular weakness or inadequate inspiration, the total alveolar volume is also reduced. But the DLCO may be relatively normal in these patients. But the total DLCO by VA, KCO may be increased, but the DLCO is decreased. So the seeing the percentage of DLCO to the total volume also becomes important. This will be shown to you or it will be seen in the report itself and you can calculate the percentage. So in emphysema, you can see that the total alveolar volume is reduced, DLCO by VA is also reduced, and the DLCO is also reduced. In interstitial, in alveolar hemorrhage, so alveolar hemorrhage is one of the conditions where you see an increased DLCO, because there is already blood inside the alveoli, and blood itself is a very good factor for conducting the carbon monoxide. So it diffuses more fast, and hence you get an increased DLCO. So in pulmonary alveolar hemorrhage, where you are suspecting like alveolar hemorrhage conditions, you will find that the DLCO is increased rather than reduced. So just few slides I'll like to show on impulse oscillometry also, which is a new kid on the block, not new anymore, since few years it is there. So what it does, what are you seeing in impulse oscillometry? Basically, you are sending a sound wave and you are seeing the resistance to the propagation of the sound wave. Depending on the resistance to propagation of the sound wave, you come to know whether there is an obstructive airway disease or an restrictive airway disease. So basic principle is that when there is a pressure, it is pushing the flow and the resistance is blocking the flow. So you are able to calculate the resistance and you are able to see the flow. So basically you see impedance, resistance and reactance. So basically you have a resistance which shows how much airway resistance is there, which shows the obstructive component. You have the reactance X, which shows how much restriction is there or how much the compliance has been affected, which reflects the small airway disease as well as it reflects about the interstitial disease. So you come to know both of these things in a more accurate way by doing the impulse oscillometry. The main advantage, we will not go too much into the theory of this, but see, basically you have the airway and you have R5, which gives the resistance of the total airway, R20, which gives the resistance only of the upper airway. So you can calculate the difference between the total airway resistance as well as only the upper airway resistance, so you get the small airway resistance. So basically this is what you see. You see resistance in the large airway, R5, you see the resistance total airway, R20, and you see R20 minus R5, which will give the resistance of the small airway. So this is actually a very sensitive test for small airway obstruction, which is not very clearly seen in the main lung function test. So this is about the airway resistance. We will not go too much into detail. So you see in the various hertz, you are able to see the airway resistance. And another thing what you see is the reactance. So in the reactance, what are you seeing? The sound wave is going. So you see there is an inertia of air in the respiratory column. That inertia of air has to be bypassed by the sound wave. So depending on that inertia, you will get a reactance. So basically reactance is capacitance plus inertance. So these are all. So elastic recoil gives the capacitance. So you have the sound wave which is going, you have the air volume there which is resisting, plus you have the elastic recoil of the lung which is resisting, which is giving the capacitance. So these two will give an idea of how much elastic recoil is there, how much stiffness in the lung is there, how much interstitial lung disease is there. So basically that is the principle, and this is how it looks. You get a small curve. In that curve, you can see resistance in the first upper image and you can see reactance in the lower image. And basically from the shape of the curve itself, you can make out whether this is a normal curve, whether the area under curve is decreased, area under curve is increased, and where that curve is meeting the baseline. So you can actually see this picture where you can see the normal airway and the normal lung volume. So the round is the lung parenchyma. So if it is normal, there will be a normal R and a normal X5. In damaged alveoli, you will have a normal resistance, but the X5, that is the capacitance and the reactance, that will be affected. In airway obstruction, the R will be abnormal, but the X part will be normal. So R gives resistance, X gives capacitance. R gives the airway obstruction, X gives the interstitial part or the recoil part, and also the small airway part. And if both are affected, both get affected. So this is how the curve looks like, where you have a C portion and I portion. It needs to be a little familiarity to interpret, but the big advantage of the impulse oscillometry is that even children can do. You don't need so much cooperation of the patients. Like you saw, this patient was finding it so difficult to do the test. Blow, 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 blow properly, get the proper curve. In the FOT, all the person needs to do is blow in and blow out normally. They don't need to blow hard, they don't need to blow this, so it becomes much easier to do. Many of the patients who are not able to do the normal spirometry, they're able to do the FOT. So now more and more, as people are getting more and more experience in the FOT, we are able to interpret more. But usually we need to do the FOT along with the PFT. FOT as a standalone test, we are not able to interpret very well. So this is how you can differentiate between central and peripheral obstructions. So this is where you can see it in COPD, asthma, bronchopulmonary dysplasia, obstructive sleep apnea syndrome, interstitial lung diseases, response to bronchodilators, bronchoprovocative testing, everything you can get. So you see the baseline value and you can see the post-bronchodilator value. And these are the different images, like how you get restriction, obstruction in the lung function test. Similar way, you can get curves showing obstruction, proximal obstruction, restrictive lung disease in an FOT as well. So yeah, don't want to talk more about that. So to conclude, it is easy to perform. There is passive cooperation only is required. It is well reproducible, gives information regarding central and peripheral airway obstruction. So,
Thank you, Dr. Jayalakshmi. Due to some personal commitment, ma'am has to leave early. So I'll request Dr. Sarika to felicitate Dr. Jayalakshmi. We still have a talk. Dr. Paresh Mehta and Dr. Sarika to felicitate Dr. Jayalakshmi, ma'am. Please be seated. Now I request Dr. Kinjal Modi to please get the other speaker on Dr. Thampi, sir.
GOLD टाइप करना GOLD ULD आया नहीं सर्च फॉर GOLD आप इधर सर्च करो ना GOLD स्लाइड हाँ यही है हाँ ऊपर वाला बाद में डिलीट कर देना है हाँ पॉइंटर का है पॉइंटर ये पॉइंटर है तो ऑन नहीं वो है Okay. Good evening, everybody. At the outset, I would like to thank the Borivali BMB and Dr. Kinjal in particular for, and of course the ACCP Western India chapter for giving me this opportunity to share a few words and my concepts on basic history and on the basics of spirometry. Well, I'll go slowly and basically I want you to understand, and for the purpose of which I have used the original slides, teaching slides from the Global Initiative on Obstructive Lung Disease, the GOLD guidelines PowerPoint, so that it will be easy for you to understand. Now, before we go into it, let's go into the key historical developments of spirometry. Now, ancient roots as far back as 129 to 200 AD, Roman physician Galen conducted early lung experiments using an animal bladder as a rudimentary lung, though inaccurate, air measuring device. The father of spirometry, however, in 1840s was John Hutchison. He developed the collapsible Bell spirometer, a device that allowed for precise measurement of air volume. In 1846, the same gentleman, John Hutchison, an English surgeon, invented the first accurate water seal spirometer to measure vital capacity as a predictor of longevity. He introduced the term vital capacity and linked it to height and age, as Dr. Kinjal mentioned, that spirometry should be linked to height and age. While early, less precise methods existed, Hutchinson standardized the measurement of lung volume. Despite its potential, spirometry was mostly used for research or life insurance actuarial calculations for the first 50 years, rather than routine clinical care. Subsequently, in 1947, Tiffano and Pinelli introduced the concept of timed vital capacity, later known as forced expiratory volume in 1 second, which is essential for diagnosing airflow obstruction. So as we go by, I will explain these terms one by one to you. They are simple to understand and you will go home with the concept. Then the modernization. Throughout the 20th century, the bulky water-sealed devices were replaced by lighter electronic machines, devices, pneumatic systems, and more recently, ultrasonic sensors. So, spirometry is the gold standard for obstructive airway diseases diagnosis, right? Underuse leads to inaccurate diagnosis, and widespread uptake has been limited by concerns over technical performance of operators. As you saw in the live demonstration, it is quite difficult to perform, and the technician himself has to be trained. So as we go by, I will touch on that as well. Difficulty with interpretation of results, lack of approved local training courses for these technicians, and lack of evidence showing clear benefit when spirometry is incorporated into management. So let's come down to the basics. Spirometry is a method of assessing lung function by measuring the total volume of air the patient can expel from the lungs after a maximal inspiration. You saw the way the so-called patient was asked to take a deep breath and then blow it out, right? So we measure that, and I will show you what are the parameters we can derive from that. So why do we perform spirometry? We measure airflow obstruction to help make a definitive diagnosis of obstructive airway disease, confirm the presence of airway obstruction. We also assess the severity of airflow obstruction in obstructive airway disease. We detect airflow obstruction in smokers who may have few or no symptoms. This is even before they become symptomatic. In smokers, we can pick up the fact that they have some small airway obstruction. Monitor disease progression in a known patient of obstructive airway disease. One aspect of response to therapy is also can be assessed, and we assess the prognosis in obstructive airway disease, and we also use it to perform pre-operative assessment. Various other additional uses of spirometry is to make a diagnosis and assess severity in range of other respiratory conditions. We'll talk about those. To distinguish between obstruction and restriction as causes of breathlessness. This is important because both will come to you as doctors. You will be faced with this dilemma. The patient says, I'm breathless. I can't walk a few steps. I get breathless. So you don't know whether this is due to asthma, an obstructive airway disease, a COPD, or is it because of restrictive lung disease due to various other interstitial lung disease, etc., etc. So it also screens workforces in occupational environments because there are people who are exposed to dust within their area of work, and many of the workers who are exposed to that kind of dust develop airway diseases or interstitial lung diseases. So it assesses fitness to dive, and it also performs pre-employment screening in certain professions, particularly for divers, submariners, and pilots. I've been in the armed forces, so we used to have an annual checkup of all these personnel when they are in their profession, because it's a very risky business, what you're doing underwater or when you're flying very high, where there is depressurization or there's increased pressure below the seas. And the types of spirometers, we started with bellows spirometers, which measure volume mainly in lung function units. Then electronic desktop spirometers started coming in, which measure flow and volume with real-time display. Then came in the small handheld spirometers, which are inexpensive and quick to use, but they may not have a printout. Now, this is the volume measuring spirometer, as you can see here. And that's the flow measuring spirometer. We will discuss what is the difference. And this is a desktop electronic spirometer. Here is a small handheld spirometer. Many of you all might have seen this kind of device being used in clinics, right? Now, what are the standard spirometric indices which we actually look for to label a patient having obstructive airway disease or restrictive? So the most important is the forced vital capacity. Sorry. Yeah. So this is the forced vital capacity, the total volume of air that can be forcibly exhaled in one breath. As you saw the patient taking one deep breath and then blowing it out completely. So this is the forced vital capacity. Then we look at the forced expiratory volume in 1 second, FEV1. V1 stands for 1 second. The volume of air that is expired in the first second of the blow. So you keep on blowing FEV1, FE2, 3, 4, up to 6 seconds. That is what we normally take as the, you should be able to continue blowing up to 6 seconds. And particularly in obstructive airway disease, you may not be able to expel all the air in your lungs even beyond 6 seconds because there is obstruction in the airways. Then the FEV1 FEC ratio. This is very important. This is the fraction of air exhaled in the first second relative to the total volume exhaled. Okay, now we will discuss how this is important, right? The vital capacity, of course, the volume of a full breath exhaled in patient's own time and not forced. The forced vital capacity is when he forces it out. Vital capacity is a gentle, right? Often slightly greater than the FVC, particularly in COPD, as I mentioned, because if you blow for a longer time in COPD, which is required because of the obstruction. FEV6 is the forced expired volume in 6 seconds, which is the normal time for a person without obstructive airway disease. Often approximates the FVC, easier to perform in older and COPD patients, but role in COPD diagnosis remains under investigation. The mid-expiratory flow rates, this is very, very important because it is derived from the mid portion of the flow volume. I will show you flow volume curve, and it is useful for the diagnosis of small airway obstruction. When you talk about mid-MMEF, you're talking about the middle flow period from FEV1 down to FEV6, the mid-expiratory flow, which is FEF 25 to 75. The forced expiratory flow from the 25th portion to the 75th portion of the flow volume, which indicates the small airways. You know, that is where we can get the airway obstruction in the small airways. Now look at this lung volume terminology. Now we have been talking about all this FEV1, etc. But look at this. Now we know that this is the total lung capacity or TLC. This is the tidal volume, isn't it? Which you normally breathe in and out, right? And then you take a deep breath, okay, so that you reach your inspiratory capacity. And then you blow out, and then you reach the vital capacity. You see the vital capacity from there to there. So what is this? This is the volume that remains in the airways which you cannot expel. This is called the residual volume, right? So all these are the terms that we are been talking about. And now we'll look at some spirogram patterns so that you will be able to interpret them. Of course, Kinjal will deal with it in depth. I'll just skim through it. So what is the normal spirometry? The predicted normal values. They are affected by age, height, sex and ethnic origin. Unlike, other tests where you have an absolute normal, here we have a predicted value. For your age, for your height and for your sex, there are certain nomograms which come out. That is your predicted 100%, right? What you should have. And it differs from individual to individual depending on your height. Look at that. So obviously this person's height and this lady's height, there will be a lot of difference. So how can you compare that? So we cannot compare across the population. So what we do, we look at the individual, the age of this person, we look at the height of this person, the sex and ethnic origin. This is very important. If you have a huge Pathan who is 6'7" and you try and look at it, a small Nepali Gurkha, is it fair to compare their lung functions? Obviously, there are going to be a lot of gross errors in that. Gross error. So therefore, we need to look at the nomogram, the ethnic origin of those people, like Europeans. You can't compare the European nomogram with the Indian population. So we need to draw up our own population nomograms, and which have been done. And those are which are fed into our computers, the PFT machines, right? So having said that, this is the importance of understanding the predicted normal values. There are no absolutes. It is a predicted normal value for you. It will be different from the predicted normal value for you. Okay? So having said that, FEV1, this is the criteria for normal post-bronchodilator spirometry. Like if you have an FEV1 which is more than 80% of the normal, okay? And FVC is more than 80%. The FEV1 by FVC is more than 0.8. Okay? Now I will show you that. Yes. So look at this. Now this is the volume. I hope you can see this. This is the volume on this. This is the X and this is the Y. You see the volume liters, 1, 2, 3, 4, and the time, right? Now look at this. So in the FEV1, the first second, let's look at this. In the first second, almost 4 liters have been blown out. Almost 4 liters have been blown out by this patient, right? Now, what happens? This is the total forced vital capacity, the total air which can be expelled by that patient. It is 5 liters, right? So you understand how the forced vital capacity and the FEV1 relationship, right? Now, what happens? FEV1 by FEC comes to 0.8. So this curve for this patient, the PFT is normal if it's more than 0.8. Are we clear? This is how we establish that there is no obstruction in this patient and it's a normal PFT, right? Now, let's look at one with obstructive airway disease. What happens here in the volume time curve, right? So look at this. This is obstructive disease, right? That is the normal. We know this. We have seen this curve. Now, what happens in an obstructive disease? Look at that. What has happened? In the first second, how many liters was expelled? Hardly 1.8 liters. FEV1, 1.8 liters. Why? As against 4 liters in the normal person. Why 1.8 liters? Because there is obstruction. There is obstruction and the patient is unable to blow out the air in his alveoli or in his lungs, right? Because there is obstruction en route. And therefore, he is able to blow out only 1.8 liters out of the expected 5 liters, right? Now, because of obstruction, the amount of air that he can totally expel is also reduced. As you can see here, the FEC is 3.2 liters. 3.2 liters. Are we clear? We are understanding this? Are you able to follow? Right? Now what happens? Sorry. Yeah. So if you see the FEV1 by FEC here, it is how much? 0.56. This is less than 0.8, which we take as the normal, and therefore this patient has got fairly moderate to severe obstruction, airway obstruction. Are we clear? Okay. Now, pyrometric diagnosis of COPD, we know. COPD is confirmed by a post-bronchodilator FEV1 by FEC of less than 0.7, right? So 0.8 is the cutoff. Above 0.8, normal. Below 0.8, obstructive airway disease, right? The post-bronchodilator FEV1 by FEC measured 15 minutes after 400 micrograms of salbutamol or equivalent, right? 2 puffs. And then you measure it after 15 minutes, which I will show you, right? It provides the best achievable FEV1 and FEC. Which one? The bronchodilator, sorry. The bronchodilator testing, reversibility testing. How do we decide whether this patient has got an obstruction which is reversible or whether it is a permanent obstruction and it is not having adequate reversibility? Most of us know, all of us here at least, that asthma is a reversible obstruction, whereas COPD is a partially reversible obstruction. Okay? So, this helps to differentiate COPD from asthma when you do the reversibility testing, right? So, it must be, of course, interpreted with clinical history. Neither asthma nor COPD are diagnosed on spirometry alone. Please listen to the patient, take a proper history, and only to confirm your suspicions should you reach out for your spirometry or lung function testing, right? And the bronchodilator reversibility testing can be done on first visit if no diagnosis has been made. It is best done as a planned procedure. Pre and post bronchodilator tests require a minimum of 15 minutes, as I told you. Post bronchodilator only saves time but does not help confirm if asthma is present, but that I'll tell you how. Short-acting bronchodilators need to be withheld for at least 4 hours prior to the test, right? So here are the various drugs which have been used for testing. The salbutamol, as I told you, either 2 puffs, and you do the FEV1 after 15 minutes, and you'll find that the FEV1 has improved. Post bronchodilator FEV1 is what is important. Terbutaline or ipratropium. Okay, these are less used, but we normally, all of us use salbutamol because it is readily available and easily accessible. Okay, so how do you prepare for a bronchodilator reversibility testing? Tests should be performed when patients are clinically stable and free from respiratory infection. Very important. If the patient is walking into your OPD with an acute LRTI, lower respiratory tract infection, that's not the time to send him for a PFT. You treat him, let him become stable, and when he's in a stable condition, please send him for a PFT. So they should not be performed when patients are having any respiratory infection. Patients should not have been taken short-acting bronchodilators in the previous 6 hours. This is very important. You need to ask the patient, have you taken any Asthalin, salbutamol or any levosalbutamol inhalers before in the last 6 hours? Long-acting bronchodilators like salmeterol, etc., or formoterol in the previous 12 hours, because they have a duration of action up to 12 hours. And sustained release theophylline, we often forget that the patient is on sustained deriphyllin retard or something like that. And then you put you make sure that the patient hasn't taken that in the last 24 hours at least. FEV1 should be measured minimum twice within 5% of or 150 ml before a bronchodilator is given. So you need to get 2 curves at least. The bronchodilator should be given by meter dose inhaler through a spacer device or by nebulizer to be certain it has been inhaled. The bronchodilator dose should be selected to be high on the dose response curve. Possible doses, as I told you, 400 micrograms of salbutamol or 160 micrograms of ipratropium. And FEV1 should be measured again after giving the bronchodilator 15 minutes after the short-acting bronchodilator and 45 minutes after the anticholinergic like ipratropium, etc. An increase in FEV1, that is both. Now, what is significant change? Once you have given done the baseline FEV1, then you have given the bronchodilator, 2 puffs of salbutamol. What is a significant change in the FEV1? What do we take as significant? So, an increase in FEV1, that is both greater than 200 ml of the pre-bronchodilator and 12% above the pre-bronchodilator FEV1, baseline is considered significant. So, if it is less than 200 ml and or less than 12% of the predicted value, then it is not significant reversibility. Therefore, it does not fit into a diagnosis of bronchial asthma. Right? It is usually helpful to report the absolute change in ml as well as the percent change from baseline to set the improvement in clinical context. Because once you say that the patient has 200 ml, you know that this person has a significant bronchodilator response. Now, as against obstructive airway diseases that we have been discussing, let's look at restrictive lung diseases, right? So, here, what happened to the FVC? It is usually less than 80% predicted. The forced vital capacity is less because of restriction, fibrosis, the ILD, or various muscle disorders, neuromuscular diseases, the lung capacity is reduced. So, the forced vital capacity is what is most important. The FEV1 may be normal or slightly reduced.
Sorry, sir, but last 5 minutes.
Okay, yeah. And FEV1 by FEC will be more than 0.7. So, there is no obstruction here, right? So, let's look at this. That's the normal curve which we have seen. And then you have the restrictive curve. So, what happens in the restrictive curve? The FEC, sorry. Yeah, sorry. Yeah, this is the restrictive one. And see what happened to the FEC. The FEC is 2 liters. That means the total capacity of the lung has come down from 5 liters, which is there, to 2 liters. And the FEV1 is almost normal, 1.9 compared to the 2 liters. So it is more than FEC, FEV1 by FEC is more than 0.95, right? So I hope you understood. And let's leave the mixed obstructive and restrictive because it basically, if you understand obstructive and restrictive, that is enough. Okay? So I will not go into this and confuse you. But it is basically restrictive and mixed are difficult to diagnose by spirometry alone. So full respiratory function tests are usually required, such as body plethysmograph, DLCO, etc., which Dr. Jayalakshmi had explained. Now, flow volume loops, they are standard on most desktop spirometers, adds more information than volume time curve, less understood but not too difficult to interpret, and better at demonstrating mid-air flow obstruction. Now you see this. This is the inspiratory limb. This is the inspiratory limb. You saw when the person blew on the computer, this was the inspiration. Okay? And this is the expiration. So as you see, residual volume, I showed you, the forced vital capacity, the total lung capacity, as you can see here, and the expiratory flow rate and the inspiratory flow rate. Now, in obstructive, the pattern is like this, where there is delay in the obstruction. And you see severe obstruction, even further delay. You see this almost running parallel to the baseline. And in restrictive, it is the volume which is affected. That is, this is the volume, this is the flow, right? So I think we can just look at this. This is the normal curve. In obstruction, we can have here and here. This is the obstructive pattern. Shows rise, reduced volume expired, prolonged time to full expiration. And in restrictive, the volume is reduced, right? And in mixed, of course, you can have that kind of pattern, right? Sorry. Now, performing spirometry, I'll just take 2 minutes to explain to you, but there are lots of theory in that. I will not go into all that. It is important to train the trainers, that is important. And it is obtaining predicted values, as I mentioned earlier. Choose values that best represent the tested population, right? Optimally, subjects should be resting 10 minutes before performing spirometry. They should withhold all these drugs, which I had mentioned earlier, and explain the purpose of the test. You saw how it was explained, what the test was done. Record the patient's age, height, and gender. Note when the bronchodilate was last used. Have the patient sitting comfortably, loosen any tight clothing, and empty the bladder beforehand, right? And breathe in. You saw the procedure, so I will not explain this any further. And watch the patient during the blow. Check to determine if an adequate trace has been achieved. Otherwise, repeat the procedure at least twice more until ideal 3 readings within 150 ml are reached. Within 150 ml or 5% of each other are obtained, as is shown on this one. You see that? See this graph? Okay, they are within 150 ml or 5% of the predicted each. So therefore, this can be taken as
Sorry, sir,
acceptable.
but we like literally out
so
of time.
that's all. Yeah, I think that's all I had to say. That's my, there are various things about quality control and common problems. I will not go into that. But if there are any questions, I'll be very happy to take them.
Thank you, sir. And I would kindly request Dr. Sarika Katkuri to felicitate Dr. Thampi.
So huge round of applause for Dr. Thampi. So I'll invite Dr. Paresh Mehta sir to please come on stage. Yeah, and all committee members, please be ready for the group photo. So now we'll quickly move on with the bumper lucky draw for today's evening session. That would be a silver coin. So I'll request Dr. Paresh Mehta sir only to do the honors. Please get the bumper lucky draw. We'll only select the doctors whose all stalls are stamped. So except the 2 stalls which weren't there, all other stalls should be stamped.
Dr. Jignesh, before that, would you like to give any?
Yeah, the instructions is the evening program we are starting at sharp 8 o'clock here. So everyone has to come at 8. The dress code we have already informed, it would be white and blue. If you haven't got it, you can wear anything, whatever you like. Another thing, tomorrow checkout would be, we are starting our MEDIMEET at 10 o'clock here sharp. So your checkout would be at 9:30. For the delegates whose family members are here, they can check out the room at 11, non-medicos. But the ones who are traveling solo and who are a BMB delegate doctors, they'll check out and they'll keep their luggage at the designated spot where you are dropped off on day 1 on the left hand side of the entrance. So kindly drop your luggage there and you have to be here by 9:30. Finish your breakfast and be here by 9:30. Don't wait for carnival tomorrow morning. We are starting our session sharp at 10. Before that, we'll give a bumper prize tomorrow morning. So there will be 1 gold coin which will be given tomorrow morning before we start. So don't miss it. If you are late, then you might just miss a chance to win a gold coin.
Tomorrow there are plethora of prizes, 2 gold coins, 1 silver coin and lots of bumper prizes which till now not many have claimed. So be ready and be on time. As per the this coupon drawn today, all the stamps as required have been done, and who would be the lucky person?
So just check it, all the stalls.
It's there, it's there. It's Dr. Kalpesh Dave, last bencher. Congratulations.
Last benchers are the most intelligent people. See, jackpot sir नहीं लिया है last में बैठ के. Lucky. So sir will be receiving a silver coin. Please clap for Kalpesh sir. आपको नहीं मिला इसका मतलब ये नहीं कि उनके लिए तालियां नहीं बजाने की. You still have tomorrow, so you'll get a chance to win. Delegate return gift, we'll give it after dinner tonight. So don't rush back to your room after having your dinner. Your delegate gift will be given after post dinner tonight. Yeah, and tomorrow morning we won't entertain anybody coming with coupon to collect the delegate return gift. So do make a point to collect it tonight itself. Yeah, so that's it, sir. See you all at 8 o'clock here. Thank you. I'll request all the committee members to please be on stage for a group photo. Just one sec. Okay. Yeah. All the committee members.